Good morning. Good morning. Welcome, everyone. This meeting will now come to order. This meeting of the California Healthcare Affordability Advisory Committee. Please note that this meeting is being recorded, and I will first ask our facilitator, Jane Harrington, to do a roll call of our members.
Good morning. Thank you, Director. I'll go around and do roll call. As a reminder, you have a mic in front of you. So for the purposes of hearing in the room and also our recording and also our virtual guests, please make sure to press the button so that you see the green light go on when you say that you are present, and then press the button to turn it back to the red light. Let's get going. Joan Allen. Present. Barry Arbuckle.
Present.
Aliza Arjoyan.
Present.
Stephanie Klein. Carmen Comsty. Adam Daughtery. Parker Duncan Diaz.
Present.
Hector Flores. Sarah Gavin.
Present.
Stacy Huertas.
Present.
David Joyner.
Present. That's teamwork right there.
Ivana Krasinovich. Tam Ma.
Here.
Carolyn Nava. Mike O'Day.
Present.
Janice O'Malley.
Present.
Sumana Reddy.
Present.
Yolanda Richardson.
Present.
Kieran Savage Sangwan. Andrew C.
Present.
Sarah Sorokin.
Present.
Ken Stewart. Suzanne Usage.
Present.
Yvonne Wagner. Renee Williams.
Present.
Anthony Wright.
Good morning.
Abby Young.
Here.
We can come back to Carmen
Great, thank you.
and Stephanie.
Wonderful. Carmen Comsty
Present.
and Stephanie Klein. Thank you. Thank you.
And Adam Doherty. Wonderful. Thank you all for helping us out. There are a lot of you, and we're so pleased to see you. Thank you for being here, and thank you for engaging with us in this important work. So with the roll call, that will establish our quorum. And we will move on to our member oath of office and introductions. So I'd like to start by welcoming members who were not able to join us at our last meeting. Thank you for being here. When we met for the first time in June, we had a few members that were selected just the day before, and so they weren't able to join us, and some of the others may not have been able to join us, so we're glad that you are here. As we did at that meeting, I will ask you now to take the oath of office if you did not do so at the June meeting, and also invite you to introduce yourselves, so we'll have a minute to do that. But first, we will take the oath of office. So again, if you did not take the oath of office at the June meeting, would ask you to repeat after me. I and your name do solemnly swear that I will support and defend the Constitution of the United States and the Constitution of the State of California against all enemies, foreign and domestic. That I will bear true faith and allegiance to the Constitution of the United States and the Constitution of the State of California. That I take this obligation freely without any mental reservation or purpose of evasion. And that I will well and faithfully discharge the duties upon which I am about to enter. Wonderful, thank you. We will also, our team will follow up with you to get you to sign a copy of that oath, and we appreciate you being here. So we'd like to give each of you, again, who were not at the June meeting, the opportunity to introduce yourself, and specifically to talk about your name, your role, your organization, and what drew you to this work. Why did you apply to be on the advisory committee? If you were watching virtually last time, you saw that we had folks who very well modeled for us how to do that in 1 minute. We have a lot on the agenda, a lot of voices to be heard from. So would ask that you go ahead and cover that information in just 1 minute if you're able to. So first, I'm pleased to ask Eliza Arjoyan to start off by introducing yourself, please.
Good morning, everyone. Eliza Arjoyan. I'm Senior Vice President of Network Management and Provider Partnerships at Blue Shield of California. And what drew me here on a professional level is just the amount of healthcare costs that we have to contend with as a health plan, but also hearing it from our providers, from the independent physicians, from our larger systems, from the hospital systems, and the amount of issues that are predominant with affordability today is something we all need to take accountability for. And then on a personal level, as most of you, I'm sure, I've become sort of the healthcare advocate for all of my family and friends and our neighbors. And it's been really difficult, especially for the last 3 or 4 years, maneuvering through the healthcare system. And when patients get bills, and my parents can't understand what the bills are for and the enormity of those bills. It's just become a real challenge. And what drives me here is, what are all these other people that don't have someone like us to help them manage through the system? What do they do? And so those are the 2 primary reasons I'm here. Thank you.
Thank you so much. Thank you. Stephanie Klein.
Currently, I'm a Kaiser Permanente respiratory therapist. I've been at this Kaiser for 18 years, but probably worked for another Kaiser prior. I've also worked for Sutter. I've also worked for subacutes. I've worked for small rural hospitals. I'm also sitting on the board of directors for the largest fire protection district in California, the South Lake County Fire Protection District. I'm also a veteran through Desert Storm, Desert Shield as an Army reservist, and later as an Army National Guard, making the rank of sergeant. 14 years of duty. I could keep going on, but I'll save all of that. I'm here primarily because, like everybody, the pandemic changed me. But what I saw, the disparities in healthcare, the disinformation, I fought a pandemic within the pandemic, and I'm still fighting it. What I saw were a lot of people who, if they were provided access, early access to care, diagnosed with their prediabetes, their hypertension, that they may not have died. And I had to iPad with plenty of 40-year-old Hispanic men dying. And I tried to blow the whistle. I was told that I could not talk about it because it was proprietary data. I was told there were a lot of things I could not share with the public. And so hopefully I can come forward and help make a difference to the people, the weakest, most vulnerable members of our society, and make sure that more people have access to quality care. We are the richest nation, one of the richest nations in the world, and I find it ridiculous and appalling that we are not helping people get access to quality care. Thanks.
Thank you very much, Stephanie. Next, I would turn to Peter Duncan Diaz. Parker Duncan Diaz.
Yeah, my alias is Peter Parker, but none of you want to see me run around the walls today, but a couple more of these and I might. So I'm Parker Duncan Diaz, and hello to all. Happy to be here. I'm a family doctor. I live and work in Santa Rosa, California, where I also went to residency. I work in FQHC, so I come here with a perspective of dedicated clinical service. I do full spectrum family care. I was in the hospital catching babies last night. And so that's really my bias. I come here as a clinical perspective with a deep dedication to the underserved. My particular interest in training was in the Latino health underserved. And I also come to this with a general then strong push, like it sounds like many others, for a belief in universal health care. And then I'll also add in that I like government, but I like a little bit of government, and just the right amount seems hard to find. Also, as a U.S. military veteran of 2 Gulf Wars, I appreciate the role of strong government presence, and it also needs to have some direction. So very happy to be here.
Thank you for being with us. Mike O'Day.
Hi, everyone. Mike O'Day, Senior Director of Health at Children Now. We are a statewide policy research and advocacy organization focused on kids prenatal to age 26. I am interested in this work because we can't talk about coverage and access and outcomes for kids and their families if we're not thinking about affordability. So really appreciate being here with this group. Thanks.
Thanks very much, Mike. Janice O'Malley.
Hi, good morning, everybody. Janice O'Malley. I am a legislative advocate with the American Federation of State, County, and Municipal Employees. We represent many working folks, not just in the healthcare setting, from our healthcare workers and our nurses and our docs, but we also represent folks who work in behavioral health, EMTs, paramedics, as well as your bread and butter public sector folks and childcare providers in the state. I'm really excited to be here. My previous position, I was with the California Labor Federation and worked very closely with Dr. Pan and Tam and with a lot of folks here in the room like Joan on establishing the office. And, at the end of the day, our public sector workers, our union members, we at the bargaining table see the driving down of wages as a result of these skyrocketing costs of healthcare. And so I'm really excited to see how we can move forward in this innovative space with the office. So thank you.
Thanks very much, Janice. Sarah Sorokin.
I'm Sarah Sorokin, and I'm a licensed marriage and family therapist. Currently, I do assessments of children and adults at Solano County Behavioral Health, linking them to needed mental health treatment. And I'm driven to this work because as a frontline healthcare worker, I see, and also as a person who needs healthcare with loved ones who need healthcare, I see how our healthcare system really fails us, and wanting to help contribute to the fight to make healthcare a right and not dependent upon how much money you have. And also for my healthcare colleagues and peers who I do see working under very challenging and unsustainable conditions.
Thank you, Sarah. Am I right that we've now had everyone introduce themselves who's here either at the last meeting or this meeting? Wonderful, terrific. I'd also like to acknowledge that we are joined by Dr. Richard Pan. The statute requires that at every advisory committee meeting, we have at least one board member, 1 or 2 board members. So appreciate that Dr. Pan is here joining us today. As you've noted, if you've been watching the board meetings, it's important that the input from this group is communicated to the board. So the staff will be communicating tomorrow on some of the agenda items, some of the input that we got, and then Dr. Pan is here importantly to add his perspective and hear the important input that each of you have. I'd also like to acknowledge our co-facilitators. So we're working with Leading Resources to have an external neutral third party to facilitate our community meetings. This allows our staff members to fully participate in the discussions and helps us move through our agenda items. So pleased to have Jane Harrington with us today. So we do now have the opportunity for any public comment on this agenda item of the oath and the introduction of board members. If you have comment on another item, please hold that. But if there are any public comments on this agenda item, now's your opportunity. Okay. Moving on to item 3, director's remarks. That's me. So I'd like to start my update by highlighting a report that really centers the healthcare affordability conversation on consumer needs and challenges. And so those of you who introduced yourselves today, and certainly those who did in June, and the work of this office is very much centered on consumer affordability. So like many of you, we of course are following the studies and research as it comes out. I think most of us know from our own circumstances, and as Eliza said, just working with our family members and friends, we have plenty of anecdotal information about the lack of affordability, and also important to be evidence-based and track the research coming out. So in August, the think tank Third Way reported that middle-income Americans, those earning between $50,000 and $100,000 a year for a family of three, are the most likely group to be saddled with medical debt, with nearly 1 in 4, or roughly 17 million Americans who have unpaid medical bills. The middle class medical debt problem holds across all demographics, races, ethnicities, education level, age, parental status, health, insurance status, and geography. But the report really shows that middle income families are slightly more likely to have medical debt than lower income families. Luckily, many lower income families are on Medicaid or Medi-Cal in California, although also tragically, some of them just go without care. And that's part of why they are less likely to have medical debt. Middle income families are also less likely than higher income families to have the disposable income to pay high deductibles and other out-of-pocket costs. This latest report continues to highlight the growing and seemingly intractable problem of medical debt and its consequential life-altering impacts on American families, such as increased risk of eviction, food insecurity, and negative health outcomes as a result. So again, just keeping our eye out on the research there that continues to show the need for this work. Moving on to some HCI departmental updates. And I'll start with the Healthcare Payments Data Program, or HPD, and we're very pleased to be joined by a number of our HPD Advisory Committee members, including Ken Stewart, our chair, and Anthony and Joan and others who have been with us on this journey. It's taken us 5 years to stand up California's all-payer claims database, but we're thrilled to have the first publicly available data reports, both our snapshot that came out at the very end of June and now our measures. So if you have not yet gone to our website, please do so. We want this data to be available. Come geek out with us and have fun with that data, because there's a lot that is there. On October 26th, our HPD Advisory Committee meeting will review the public reports and priorities for public reporting. And we will also have a discussion about non-claims-based payment data collection. And I'm pleased that our HPD staff is working closely with our OCA staff in these two advisory committee meetings to have a shared approach about how we collect non-claims-based data, of which, of course, there is a very, very substantial amount in California. The public comment for the HPD data release regulations has closed, and the department is reviewing those comments. And the Data Release Committee will be meeting in November to adopt their board manual and have a review of the full data release process, including user fees, the research enclave, very exciting, and the application for data release and the data use agreement. So starting in January, we'll have that opportunity for folks to apply to get access to some of the non-public data through this fancy data enclave, because we have literally billions and billions of claims and data sets for folks to go through. So we have this data enclave that folks will be able to access, and our data release committee is helping guide that work and guide our responses to applications for access to that data. Next, I wanted to highlight the efforts of our Office of Health Workforce Development. So you are all in this space and know about the healthcare workforce shortages that California faces, and so we have considerable efforts in the state of California to work to expand and diversify the California healthcare workforce. So just wanted to highlight a couple of programs currently accepting applications. First is the Health Professions Pathways Program, which is designed to recruit and support students from underrepresented regions and backgrounds to pursue health careers through pathway programs, including pipeline initiatives, summer internships, postgraduate fellowships, and post-bac scholarships. We know we're only going to succeed in our health workforce goals if we really reach out to underrepresented students and diversify our workforce. We also have a justice system involved youth behavioral health pipeline, which is accepting applications to fund organizations that encourage students to pursue careers in behavioral health. And then we have many scholarship programs currently accepting applications, including our allied health programs and several of our nursing programs. So always want to get the word out about these. Let's see, last but not least, I want to talk about our distressed hospital loan program. So that was included as part of the governor's budget. And I'm very proud of my finance team here at HCI that stood up that program very quickly in response to the need for some of the financial distress facing hospitals. So under this program, in August, we announced $300 million in distressed hospital loan awards. These are no interest loans to public and nonprofit hospitals, and we were able to make awards to 17 different entities. Our partner, CHAFA, the California Health Facilities Financing Authority, sent letters of commitment to loan recipients and is working with hospitals on preparing and executing those transaction documents. Once hospitals have executed and returned all transaction documents to CHAFA, funds will be distributed within a week. So our HCI team is now focusing on the development of potential loan modification and loan forgiveness criteria that's mentioned in the legislation. So hospitals don't have to pay anything back for 18 months, and there is a possibility of loan forgiveness, and we are now working to develop those criteria. So those are my director's reports. Again, appreciate you all being here. And with that, I think we invite public comment on this agenda item. Or do we let members go first? If there are questions or comments from committee members, Rochelle? Yeah. So if questions or comments from committee members, and then we'll go to public comment. Okay, public. Oh, yes, Carmen.
I had one question about the distressed hospital loan fund. Is for the development of the criteria of the loan forgiveness criteria. Is that something that is a draft of that criteria going to be public, or is that and what's the timeline on that?
That's a great question, Carmen, and thanks for calling that to our attention. That of course folks would want the opportunity to give input. So we hope to have criteria developed by the end of 2023, and we will look at a possibility of somehow posting or having an opportunity for folks to give input on those criteria. Thank you. Okay, public comment.
All right, we now invite public comment on that agenda item. Please reserve all other comments for the general public comment portion at the end of the meeting. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually, asking those present in this room to step towards the podium. If you'd like to make a public comment, asking those attending virtually to raise your hand. If you're dialing in, please press *5. That will raise your hand. Seeing none at this time and noting roughly 50 individuals attending virtually, that closes public comment.
I'm now very pleased to turn it over to Assistant Deputy Director Sheila Tatayan to present on the Cost and Market Impact Review Program. And Ms. Tatayan is joining us virtually.
Good morning. This is Sheila Tatayan, and I'm not sure if folks can hear me. Can you hear me okay?
Yes, we can, Sheila. Thank you.
Okay, great. Thank you. I apologize for not being there in person to see you, but a member of my household tested positive for COVID yesterday, so keeping my germs at home. So today, we will take the time this morning to go over the proposed draft regulations for our CMIR program. I know that many of you attended the workshop and some have probably watched the board meeting, so this will be familiar to you. So I will move through it fairly quickly because I'd like to have a lot of time for comments from you as well as comments from the public. We published the regulations on our website at the end of July. We held a public workshop on August 15th, and we received many comments at the workshop, which I will highlight for you. And we also received many written comments at the end of August, which I will also highlight for you. To start, I'm going to have our Assistant Chief Counsel, Heather Hoganson, go over the first 2 slides as a review of the emergency regulation process.
Greetings, committee members, members of the public. So the legislature, in adopting this statute, gave OCA emergency regulatory power, which is a little different than most agencies who are implementing legislative efforts. Normally, an agency would have to go through a full formal rulemaking, and that includes a number of very structured steps. An emergency rulemaking power, as was given in the statute, and it's up there on the screen for you, indicated that there is a pressing emergency, and so the regulatory steps are truncated. And on the next slide, you can see the difference between emergency rulemaking and regular rulemaking. So for those of you who have been involved in rulemaking efforts, either in assisting to create regulations or in responding to regulations, it's a slightly separate, different process. So a regular rulemaking process would normally have a 45-day notice and comment procedure, and that's absent in an emergency rulemaking. A rulemaking under an emergency power, there's a 5-day window for comment about whether or not it's truly an emergency. In this case, the legislature has declared it to be an emergency, so it's not really so much of an issue. In a formal rulemaking, all the comments that are received by an agency are formally summarized and responded to as part of the rulemaking file. Again, in an emergency rulemaking, that doesn't have to happen. In both cases, a draft text is sent to the Office of Administrative Law, OAL, and they review the regulation to make sure that it is clear, it is consistent with other state laws, it's following the authority given to the agency who's promulgating the regulation, etc. That still happens, but the Office of Administrative Law is on a shorter timeline. And once the Office of Administrative Law approves a regulation, under a regular rulemaking process, it generally takes to the next quarter. Under an emergency rulemaking process, it would go into effect the very next day. Now, under an emergency rulemaking process, there's a timeline by which the regulation will expire on its own terms. Normally, that's 180 days. Our statute has given us emergency rulemaking authority for a 5-year period. So we can be under emergency regulations for up to 5 years before we have to go through the formal process to finalize it. And under a regular rulemaking, once it's approved, it is permanent. So there's a little bit of difference in the process here, and some people have expressed some confusion at our workshop of how that was going to happen. So I just wanted to make sure that everyone knew the differences. So are there any questions on the rulemaking? Otherwise, I will turn it back over to Sheila. Thanks.
Thank you, Heather. So today we'll go over the July draft of the proposed regulations. And as I mentioned, I'll go through somewhat quickly so that you can ask questions and comments when I'm done going through the regulations. So we'll go over who must file, what the thresholds are, and the circumstances of the proposed transaction and whether they require filing. We've defined healthcare services for purposes of the regulation, and we've outlined when healthcare entities need to file their material change notices. I'll go over the filing for the material change notice and a summary of the information that's required, and then what happens after an MCN is filed, what OCA's process is. And then I will review what OCA will consider in making its decision to either issue a waiver for the transaction or conduct a cost and market impact review, which we call a CMIR, for the proposed transaction. I'll go over the factors, and then we'll go over the timeline, which I know is very important to healthcare entities. So starting with who must file, our statute is regulates healthcare entities, which are again defined in the statute. And as you can see, if we advance to the next slide, that includes all payers, providers, and fully integrated delivery systems, pharmacy benefit managers, management service organizations, and then affiliate subsidiaries or entities that are subject to the control, governance, or financial control of the healthcare entity. And then importantly, healthcare entities entering into the transaction with a physician organization of 25 or more physicians. So I want to be clear here because I think there was some confusion. A physician organization of less than 25 does not meet the definition of physician organization or provider, so they are exempt from filing a material change notice. However, if an entity is entering into a transaction with less than 25 physicians, that other entity must file a material change notice. So after the who, it's a question of whether the entities meet the thresholds. And those thresholds, as we advance to the next slide, are as follows. So if a healthcare entity has annual revenue of at least 25 million or owns or controls California assets of at least 25 million, that's the first threshold. Or if a healthcare entity has an annual revenue of at least 10 million or owns or controls California assets of at least 10 million and are involved in a transaction with an entity with 25 million or more, then they're subject to the filing. And then finally, if a healthcare entity is located in or serving at least 50% of patients residing in a health professional shortage area, HPSA, as defined in the CFR, they will also be subject to the requirements for filing a material change notices. And then next, if we advance the slide, you'll see that the next step is OCA will look at the circumstances of the proposed transaction to determine whether the healthcare entities are required to file notice. And we have set out 9 different circumstance factors that would trigger a filing requirement of the material change notice. So first, the fair market value of the transaction is 25 million or more and involves the provision of healthcare services. Number 2, it's likely to increase annual revenue of any healthcare entity that is a party to the transaction by at least 10 million or 20% of annual revenue, and that's at full operating. Number 3 involves the sale, transfer, lease, exchange, option, encumbrance, or disposition of 20% or more of assets of any healthcare entity in the transaction. And then number 4 involves the transfer or change in control, responsibility, or governance of the submitting healthcare entity. Number 5 on the next slide is the terms contemplate one of the entities or any of the entities negotiating or administering contracts with payers on behalf of one or more providers in the transaction involving affiliation, partnership, or joint venture. And number 6, the transaction would involve the formation of a new healthcare entity, affiliation, partnership, joint venture, or parent corporation for the provision of healthcare services in California that are projected to have at least 25 million in annual revenue or have control of assets related to the provision of healthcare services valued at 25 million or more. Number 7, the circumstance would be that a healthcare entity is joining, merging, or affiliating with another healthcare entity, affiliation, partnership, or joint venture, or parent corporation related to the provision of healthcare services, where any of the healthcare entities has at least 10 million in annual revenue. But this would exclude affiliations for clinical trials or graduate medical education. Number 8, the transaction would change the form of ownership of a healthcare entity from being a private equity owned it would change the form of a healthcare entity, including but not limited to change from physician owned to private equity owned and publicly held to privately held. And number 9, a healthcare entity that is a party has consummated any transaction regarding provision of healthcare services in California with another party to the transaction in the past 10 years. So those are the 9 circumstances that OPA would look at to determine whether the transaction meets the notice requirement. For the purposes of the regulation, we have defined healthcare services. And if we advance to the next slide, thank you. And those are, as you can see, acute care, diagnostic, or therapeutic inpatient hospital services, pharmacy, retail, and specialty, including any drugs or devices. I skipped the outpatient, I think. Anyway, number 4, performance of functions to refer, arrange, or coordinate care. And number 5, equipment, such as durable medical equipment, diagnostic, surgical devices, or infusion. And number 6, technology associated with the provision of services or equipment in items 1 through 5. So this would include telehealth, electronic health records, software, claims processing, or utilization systems technology. Now, a big question is when the healthcare entities have to file the material change notice. And so once a healthcare entity has undergone all of these tests to see whether they need to file, the statute lays out the time period for the filing. And the statute says that it has to be 90 days in advance of the transaction, with at least 90, as you can see, the statutory language says with at least 90 days advance notice of transactions that will be entered into on or after April 1st, 2024. So counting back from April 1st, 2024, we will begin collecting notices January 1st of 2024, because that would be 90 days before April 1st. And so for purposes of the timing of the transaction, we have defined entering into the agreement or transaction as the date at which any party's respective rights vest in a binding agreement, or all contingencies to the agreement or transaction are met or waived. And what that means is the projected closing date. So looking at that, a healthcare entity would say, with their partners in the transaction, when is the closing? When do we anticipate that all rights will vest and that the deal will close? And then count back 90 days from that anticipated date. The regulation also lays out the information that healthcare entities will be required to submit with their notice of material change. And so we are currently working on our system, which will be ready January 1st, 2024, so that healthcare entities can go into our portal and register and submit. These submissions must be made under penalty of perjury, and the healthcare entities will have to respond to the questions that are outlined in the regulation, as well as provide supporting documentation. And then there's also a requirement that the healthcare entities provide general information about the other healthcare entities involved in the transaction. And so hopefully, if the parties have performed their due diligence, they will have this information when they file their material change notices. The transaction information includes at a high level in the middle box, the proposed anticipated closing date, the description, a detailed description of the transaction, and then the necessity or the public impact and benefits of the transaction, because we will take a balanced approach to look at what are the impacts, and we want to hear what the parties say. Why is it necessary? What's the impact to the public, and what do they see as the benefits of the transaction? We'd also like to know whether the entities are required to file with any other state or federal agency for their transaction, such as HSR, Hart-Scott-Rodino, or any other federal agencies. And then we will be asking questions about prior transactions related to healthcare services from the same healthcare entities that are involved in the transaction. And we also will be collecting the post-transaction information that the parties expect to have. So the expected competitive impacts, any steps that the parties anticipate making to mitigate potential adverse impacts, and very importantly, what the impact is on current healthcare services and what that impact would be after the transaction would be implemented. And then also, again, very importantly, any changes to staffing levels, wages, benefits, working conditions, and protections for employees. So what happens after a healthcare entity submits their material change notice? Per the statute, OCA has 60 days to determine whether the proposed transaction will receive a waiver or will have to undergo a cost and market impact review. Now, the 60-day clock will begin, and the public will know when the 60-day clock begins. But if there is information that the healthcare entities have not provided, that clock can be tolled. So we encourage everybody to work with the office to make sure that they're providing the information that's required to stay on a good timeline track. Now, OCA may also complete its review in less than 60 days. So while 60 days is laid out in statute, it may very well not take 60 days for every single transaction to be reviewed. And then at the conclusion of the 60-day review period, OCA will notify the healthcare entities whether they will receive a waiver or whether they will be subject to a full cost and market impact review. Now, at this point, the healthcare entities will have 10 business days to request a review. And this is very important. We wanted to give the healthcare entities an opportunity to come to OCA and let us know if they disagree and why. And then our director will have 5 days to respond to that request for review and notify the healthcare entities whether the cost and market impact review will proceed or whether the transaction will be waived from the review. So at that point, when OCA decides that it will conduct a cost and market impact review, it will post the supporting documentation on its website and conduct the CMIR. I'll go back just to clarify that all notices will be public, but we will not initially post the supporting documentation for the notice. It will only be published if OCA decides to conduct a cost and market impact review. So the cost and market impact review will be over a period of 90 days with an additional 45-day extension if needed. Again, it may not take this long. And again, this time frame may be told if there's additional information that is required. At the end of that period, OCA will issue a preliminary report. And at that time, the parties to the transaction and the public may submit comment for 10 business days, which will be approximately 2 weeks. And then at the end of that time period, OCA will issue its final report within 30 days of closing of the comment period. And per statute, the healthcare entities may not implement their transactions until 60 days after the final report. So moving on to the factors that OCA will consider when deciding whether to issue a waiver or conduct a CMIR. You can see the statutory provisions that were outlined: market competitions, the state's ability to meet cost targets, or the cost for purchases and consumers. Now, in developing the regulation, you'll see that we've laid out several factors for the decision as to whether to conduct a cost and market impact review. So the office can base its decision to do a CMIR on any of the following factors. Any one or more could be a factor to proceed with a cost and market impact review. So if the transaction may result in negative impact on the availability or accessibility of healthcare services, including the healthcare entity's ability to offer culturally competent care, if the transaction may result in a negative impact for costs or payers, purchasers, or consumers, including the ability to meet any healthcare cost targets established by the board. And if the transaction may lessen competition or tend to create a monopoly in any geographic service area that is impacted by the transaction. And D, if the transaction directly affects a general acute care or specialty hospital, that's another factor. If the transaction may negatively impact the quality of care, is also a consideration. If the transaction between a healthcare entity located in this state and an out-of-state entity may increase the price of healthcare services or limit access in California, that will also be a consideration. And continuing on. These are the factors that will be considered when the office conducts a cost and market impact review. And this slide shows what the statute has laid out. I'll give you a moment to read, so give you a rest from hearing my almost auctioneer's voice. So translating the statute into regulation, in our July draft, we've laid out numerous factors that would be considered in conducting the CMIR, which would relate to the business and relative market position. And so these are including but not limited to the effect on, again, availability or accessibility of healthcare services to the community affected by the transaction, again, including the accessibility of culturally competent care, the quality of the healthcare services to the community that are affected by the transaction, and the lessening of competition or tending to create a monopoly, which could result in higher prices, reducing quality or equity, or restricting access, or less innovation. Any healthcare entity's ability to meet any healthcare cost targets, as we've discussed before, and whether the parties have been parties to other transactions in the past 10 years that have been below the thresholds for the notice requirement, because we know by experience there are serial transactions that can lead to monopolistic power. Consumer concerns. OCA will consider consumers' concerns related to complaints or other allegations against healthcare entities that are involved in the transaction. And those would be concerns related to access, care, quality, equity, affordability, or just coverage, denials of coverage. And then finally, a very broad one, any other factors the office determines to be in the public interest. So again, I did go through this fairly quickly, but I remember seeing many of your faces at the workshop and also at the board meeting presentation. So our August 15th workshop was transcribed by a court reporter, and we had approximately 120 virtual participants and 20 people in the room. At times that 120 number was higher, but the 120 is approximate. The participants included representatives from unions, physician groups, health plans, hospital systems, private equity, consumer advocacy groups, and medical, hospital, and nursing associations. And at that workshop, 13 commenters came to the podium and shared very specific feedback on proposed regulations, and we really appreciated the feedback. At the workshop, there was a general appreciation expressed for the detail of the regulations and for the lengthy opportunity over those few months and the coming months for the opportunity to comment on the regulation. So going to the overview, and this is a high-level overview. OCA set a deadline of August 31st for written comments on the July draft, and we received a total of 20 comment letters. Many were very detailed, which we appreciated, and many suggested red line revisions even. 6 of those letters came from organizations that had made verbal comments at the workshop. And again, comment letters came from unions, physician groups, health plans, hospital systems, private equity, consumer advocacy groups, and medical, hospital, and nursing associations. And I do want to call out, because there was a question just before the meeting from CNA, we did receive the comment letter from CNA. And I want to emphasize that we will be looking very carefully at the comments that we received, and we do appreciate them. This is what the rulemaking process is about. It's an opportunity for the regulated public to comment and an opportunity for the office to carefully consider those comments. So what were the comments? The written comments were very similar to some of the things that we heard at the August 15th workshop. So as to the thresholds and the circumstances that I just reviewed, in the July draft for filing notice. Some commenters, again, this is always about balance. Some said that the revenue thresholds were too low, and others said that they were not low enough. So we received some suggestions that instead of 10 to 25 million, some of the suggestions range from 3 to 6 million, or all the way from 50 to 100 million. And I know this one is sort of a hot button item, and I want people to know that we are looking at this. The inclusion of management service organizations, there were a lot of comments about that. So several commenters opposed the inclusion of MSOs as payers, and some suggested that we exempt them from filing at all. Other written commenters expressed a need for MSOs to be included because of the fact that they do have a large role in the arranging healthcare services and directing healthcare services. The timing issues. I know that the regulated public is very concerned about when their transactions will be reviewed and the timeliness of the reviews and when they can close their deals. So there was a request for clarity around the timing for filing of notice. What would OCA consider as the closing of a transaction? And then, as I just mentioned, the length of time to review the notice and the time associated with conducting a CMIR. And then there were many requests for an expedited review process. The factors for CMIR, we received many comments on that as well. Some said those review criteria were too broad and others wanted more. Some wanted clarification about the factors that would consider the benefits of the transaction. And then some requests included inclusion of a full range of reproductive and sexual health services, including contraception, abortion, and LGBTQ+ health services. There was a request for specific inclusion of behavioral health services, and then requests for including labor market impacts as a sole reason. While the regulation does have labor market impacts, this request was that it would be a standalone factor as a reason for conducting a cost and market impact review. There were concerns about confidentiality, and so there were requests about additional documents that may be made expressly confidential. Currently, the regulation identifies certain documents that will always be treated as confidential automatically. And for those that are not treated confidentially automatically, the healthcare entities would have to request confidential treatment and specify how long they wanted their documents to be considered confidential. So there were requests for additional attestations that would go along with those requests for the confidential treatment. And that healthcare entities verify that they have always maintained these documents as confidential. So for example, they wouldn't be able to request confidentiality for a document that was already in the public domain. As to the reporting requirements, there were comments that suggested 2 additional requirements: that the healthcare entities identify the source of funding for the transaction and evidence that used to determine that the transaction is beneficial. So not just a description of the benefits or why these perceived benefits would occur, but actual supporting evidence. And then others wanted more public input into the cost and market impact review process and suggested and requested that there be hearings included as well. And then as to the fees, there are no fees for filing the notice of transaction, but the cost of conducting the review per statute is a cost that can be that will be reimbursed to OCA. So there was a request at capping those costs for the sake of certainty. There were also expressions of support and opposition regarding the transactions. Some wanted to make more inclusive, some wanted to narrow the transactions, and then to also address the affiliates. Again, comments on either side: narrow or expand. And then as far as the thresholds, There were requests to require more detail on labor and staffing and benefits, as I mentioned before. There were requests to require less detail because some said the information required was burdensome. And then there was both support and opposition to the revenue definition, and then the definitions of materiality and control. And then there was support and opposition for the lookbacks or prior transactions. And this is where I was highlighting the problematic areas where serial transactions occur. So some were in favor and some were opposed to the lookback aspects of the regulation. So finally, we've laid out the timeline here as we proceed to our path to filing our regulation with the Office of Administrative Law. So we are continuing to carefully review and consider the comments over and over again. And we expect that we will be posting a revised version of the regulations in October. And then at the October 24th board meeting, we will update with the board and have a further discussion with the board on the next steps and a high-level discussion of what were the changes. And then at the end of October, on our website, we will be publishing our notice of intent for the emergency regulations. Those will be that notice will be posted online as we are required to do. And then in November, we will be submitting to the Office of Administrative Law, and there is a comment period, as Heather explained, although it is short. And that is why we've tried to build into this process opportunity to comment along the way so that we get a full view of our regulated public's comments. And then in November, sometime in November and December, we anticipate that the emergency regulations will become effective because the Office of Administrative Law will have 10 days from the time we submit to them to approve or deny the regulations. And so this is also, we can be ready in January of 2024 to begin accepting the filings. And we'll be ready to implement our system. So thank you for your patience in having me run through that fairly quickly. And I'd like now to hear your comments and to have a discussion about our proposed draft, our July draft of our regulation.
All right, any questions from advisory committee members? All right, we'll start with Ken Stewart.
Yeah, my question is, when looking at proposed transaction, will consideration be given to the fact that the successor or the new entity may have higher allowable charges that were negotiated between a health plan and the service provider that would automatically increase the cost to the purchasers and consumers? Because those would already have been in place.
So if I understand your question correctly, you're saying a post-transaction effect would be higher prices to the consumers, correct?
Yes.
Yes, so that is a factor in both the consideration for whether to conduct the CMIR, and then it's also a big factor when we would conduct a CMIR.
Okay, I just want to be sure that, for example, if a hospital is an acquiring entity, because their allowable charges may be configured differently, sometimes as a percentage of billed charges, there would be an automatic exponential increase for the same services. Just want to be sure that the review will go that far.
Yes, it's a great question, and the review, as you can see from the statutory timeframe for conducting the CMIR and what we've laid out in regulations, we've said it's a 90-day review. And when a transaction goes to a full cost and market impact review, we expect that the CMIR will be extensive.
All right, moving to David Joyner.
Thank you. Yeah, thanks for the presentation. I have a few comments I wanted to make and a question. So the first comment is that My understanding of the criteria here is that a very large number of transactions could be swept into this regulation. Have you done any analysis on how many transactions? Because I'm concerned that the criteria is very broad and you may be inundated by huge numbers of transactions to review. Have you looked into that?
Yes, we have, and it's a very good question, and we've received many comments on that point. So we've taken several months to many months in looking at this and looking at the thresholds that we set and doing some actual, I would say, empirical analysis of the dollar amounts of different types of entity transactions. And so we did give that careful consideration, but we also know that some of our factors are very broad as to what could be swept in. And so we are looking at the comments and we'll be considering that further. So again, the thresholds is something we're looking at carefully. We were pretty comfortable with the thresholds, though, based on our empirical evidence. But as far as our definitions of the types of transactions and making sure that we target the ones that we want to review. For example, some of our language about related to healthcare services could be more narrowed because we could unintentionally, based on the draft now, pull in transactions that are not really in the, that are in the ordinary course of business, but may not be a transaction we want to look at. I hope that answers your question.
Yeah, thank you. I guess I will say in things like this, it's always a balance. You're trying to have an impact on the market, but you also don't want to be swamped with so many submissions that you can't handle the volume intelligently and thoughtfully. So I think my reading of this is that you're going to sweep in too many transactions, and I would reconsider the materiality threshold. Second of all, I want to say, thinking about not all mergers or not all acquisitions are going to increase costs, and I think the amount of information that is laid out here, including 10-year lookbacks, I think is a bit excessive. So again, in terms of trying to do balanced regulation, my input would be, I think the amount of information that's collected here is excessive and will cause an unwarranted burden. I also think it's critically important that there be a way of dealing with the distressed situation. I didn't see that, and I can think of a number of rural hospitals, for example, where they're in serious financial difficulty and they're choosing between staying open or shutting down. And I'm worried that I haven't seen here a clear way of dealing with that. In some of these cases, they've been saved by merging with a larger system. And the last comment I'll make is I know you mentioned it, but it doesn't make any sense to me to include MSOs. They're administrative entities that are implementing claims payment authorizations and so on behalf of payers. It will be almost like you would go to health plans and say, we're going to require your claims department to submit a separate contribution from the health plan as if a transaction is being contemplated. So I would just emphasize, I think the MSO's inclusion doesn't make any sense to me. The entities that are buying should be regulated, but the MSOs who do the administrative functions are not the decision makers, don't set healthcare costs, simply pay based on what the entity is asked them to do. So I would just emphasize that comment you got.
Thank you. Thank you for the comments. They're very thoughtful and helpful.
All right, going in order that I've seen hands, we see Barry, Hector, Eliza, Adam, and Joan so far. Barry, go ahead.
Thank you. And just a similar comment on MSOs, because MSOs, kind of the adage over the years is when you've seen one, you've seen one. And so I wasn't sure if you were only looking at MSOs that were acting as a payor or contracting with payors, or in the situation where, as Mr. Joyner indicates, they're simply helping physicians who are tired of billing and HR and electronic medical records and all the stuff that keeps getting thrust at the independent physicians over the years. I just didn't know if those MSOs that are trying to help physicians in that would go through this process. which to me doesn't seem to be getting at what you're trying to get at. Another question on, I think it's on your slide 16, and it has to do with the size of, you mentioned that physician groups transactions under 25 wouldn't be included unless it's a transaction by a healthcare entity that fits. For example, if a hospital, through its medical foundation, and the hospital is assumed has more than 25 million of revenue, acquires a struggling single family practice office, it's probably $150,000. Would that be something that would be submitted? I mean, to me, that seems to be, we're going to get into hundreds and hundreds of transactions that might be submitted if those are the criteria. And then on your page 18, when it talks about, again, what transactions would be contemplated for submission, if a health system, for example, my health system, we have the same neonatology group at 3 hospitals. The doctors like to go from hospital to hospital to cover when the volume goes up or down. So it's a system-wide contract. It's a multi-year contract. It is easily in excess of $25 million. Is that something that you want submitted every time we renew that agreement? Again, it would seem to be by read of the definition, as would if when a hospital or frankly any entity for that matter acquires an electronic medical record. Sadly, I don't know of a EMR purchase that is less than $25 million for anything of size, clinics, dental offices, physician practices, et cetera. And then finally, and I'll shut up after this, it refers to the encumbrance of 20% or more of the assets of an organization. Every healthcare debt issuance or refinancing would in fact meet that criteria, because you have to encumber the assets in order to back up the debt. And so again, I wouldn't think you would want those submitted to you as well. Thank you.
Thank you. I appreciate the concrete examples that you've provided and how you turned them into questions.
Next, I've got Hector.
Thank you. I have a couple clarifying questions. One is, I saw that PBMs and pharmacies were involved, but I didn't see pharmaceutical companies. Are they excluded from this analysis? And number 2, there was also a comment about excluding GME programs in clinical trials. Could you elaborate on that?
Yes, pharmaceutical companies are not regulated by the statute, but PBMs are. So that's why you don't see pharmaceutical companies in the regulation. And then as far as the affiliations, clinical affiliations or affiliations for the purpose of education are what we seek to exclude. I hope that answers your question.
Yes, thanks. And I have one more. There was a comment also about practices that have 50% or more patients originating from a HIPSA. So conceivably, that could be a very small practice, but that happens to be in an underserved area. And it speaks to the volume, the sheer volume that you're going to be addressing. I think it makes sense to make sure that those services don't disappear, and that's the reason I think it's in there. But you also want to take into account that a lot of these are going to bog you down from the bigger issues that really need more attention.
Thank you. Yes, and you've honed in on the purpose of having a specific provision for underserved areas. But thank you for your comment.
All right, next up we've got Eliza, then Adam, Joan, Stacy, and Ivana. Go ahead.
Thank you. Barry and David did a wonderful job explaining in detail some of the same concerns that I've had, so I won't duplicate. But what I will share is that for the last probably 5 to 10 years, what we see as a health plan is not so much a lot of what was covered in the criteria in terms of the monopolistic practices or the rise in cost of healthcare attributed to smaller organizations, but really see those larger excuse me, more impactful entities that come into the market, and through practices of acquiring physicians really do a good job on the rise to the cost of healthcare. And so when I look at the criteria of 10 to 25 million, or including MSOs, or including technology, my concern is that it doesn't allow the deciding group to be as focused and impactful as they should be, because it does feel like it's a little overbroad, and that we're trying to potentially boil the ocean just a little bit instead of being a lot more targeted in terms of what the genesis of this issue was, and what the crux of the problem is that we're trying to solve for. Thank you.
Thank you. Thank you for your comments.
Adam.
So I'll start with a question and then make a comment and then have another question at the end. Specific to the timeline of the next draft of the regulation, just so I can understand correctly, we'll be receiving the revised draft at the end of October. You can see there's still pretty significant concerns regarding a lot of the definitions and scope. Will there be an opportunity to provide additional comments and suggestions following that next draft? And will we see anything else following those comments prior to the final regs?
So we plan to post the revisions in October and have an opportunity for comment. And we are hearing very, very similar comments, which, as I've explained, we are considering. So beyond that time period, between after October, we publish and we receive more comment, there likely won't be another open comment period, because we plan to submit the regulation to the Office of Administrative Law in November so that we can be ready by January 1st.
Okay, just so we were clear on that. I appreciate the comments regarding the sheer volume of submissions and potential triggers that we've heard here today in both in previous written and verbal comments. You know, in medicine, I practice in the ER, we have to triage. We have to see who is the sickest, who is the most concerning, and the intent of this statute is to do just that. And I would encourage the office, whether in the definitions themselves or you know, utilizing the waiver process, is to see the biggest impact and focus on those transactions. The degree that we're currently seeing is frankly going to be too large, I think, for the office to sustainably and effectively review. So my next question is, previously it sounded like the plan was to subcontract out a lot of that review process. If we want to look in the future a little bit, a use case would be Oregon, where they're doing just that to some law firms who are requiring overly onerous information not required in the statute, and racking up large legal fees to these institutions as well as a part of that process, extending them out beyond a year. So what is the plan as far as the review process itself, whether it'll be in and out or out of house with respect to the timelines?
It will be a combination of OCA staff and consultants. Currently, we anticipate that OCA staff will handle the 60-day review with some consulting services, and then the actual cost of market impact reviews will be using consultants working in conjunction with OCA staff. But I do appreciate your comments, and I do appreciate you highlighting Oregon's experience for us.
I wanted to return to Eliza, your comments. I know you said they were overly broad, but was there anything particular about the factors that you wanted to call out?
Thank you. Yes, the dollar threshold, I believe, is too low. The inclusion of the MSOs unless we further specify the type of MSOs that should be included, as well as including the technological components in the review, I feel are a little excessive. Thank you for asking.
Thank you.
Joan?
Comments on a couple of areas, starting with one that we've been touching on a fair amount of the volume of transactions that will at least trigger filing. And I feel like it's incredibly important that we get a handle on what's happening in the system. And right now, we don't know what we don't know. And so starting off with that broader net of capturing more transactions, at least for filing, will give us better insight into whether the serial transactions that we know anecdotally are a problem, how big of a problem is that systemically? And the other pockets of transactions where we may not expect something to really rise to the level of a substantial cost driver. And so I applaud the office at HCI for having started off with as broad a net as they have, and would encourage holding the line against efforts to narrow that, because this is such an important moment where we have the ability to start understanding what's happening in the system. So I am not concerned about the volume of filings and expect HCI to manage which of those go to waiver versus which go to review in a very responsible manner to manage that workload. So I would encourage keeping MSOs, particularly those that have more than just an administrative role, and keeping the filing requirements as broad as possible. On to then an issue that we haven't been touching on yet, which is the impact on the labor market. Really appreciate the inclusion of the healthcare labor market information in some of those post-transaction information about staffing and other labor market impacts. Would encourage, there's language in about utilization, and that the number of patient visits be reported by county and zip code, and would encourage mirroring that language into the staffing levels and number of employees that are required to be reported, because it would be very possible to have a statewide entity where if you're all that you're reporting is a staffing level at the statewide level, that's not really a meaningful number. And there's the recognition of that for the patient utilization data, but not mirrored for the staffing data. And then also something that came up at the last board meeting was that discussion of the FTC regs that are being, that are comment period just closed for them, that will include a new workforce section in the FTC pre-merger notification. And I see some of that reflected here, and that's fantastic, but there's another piece in those regs that I don't see reflected, which is the new FTC regs will talk about how if a firm has a history of labor violations, it may be indicative of a concentrated labor market where workers do not have the ability to easily find another job. And so the FTC for those large HSR pre-merger notifications is going to start requiring Department of Labor, OSHA, and NLRB violations, and that be taken into account. And I think that would be an incredibly powerful thing to mirror here in California, because especially in some of these already concentrated markets, that could be a very powerful indicator of what will happen to patients. Is if you have an entity with a substantial history of labor violations, then what happens to patients when that entity is expanding into new markets and increasing consolidation where they have greater power. So it would encourage mirroring all of what the FTC regs are going to be doing on the workforce side, not just some of the numbers notification. And then a third part is on the confidentiality side. And in terms of the data that is required to be filed, but is then automatically treated as confidential. I feel like there are a couple terms in there that are overly broad. Some of the terms are incredibly specific. Unredacted resume. Can see a really clear reason why that would not be made public. But financial information is a very broad term. And it is unclear whether financial information that is otherwise public would fall into the automatically private, or whether the requirement that data have been held confidential would control. And so for financial information, it's overly broad and it's unclear as to in what circumstances that would be confidential and in what circumstances it would be publicly available if it has ever been disclosed in the past. I think that does it for me.
Thank you. Thank you for your very specific comments.
Great. We'll go to Stacy, then Ivana, then Ken.
Good morning. I have a couple different comments in addition to what Barry and David have commented on. One is just to think about how much cost will go into to evaluate all of these transactions and to keep it as minimal as possible, because we're all trying to reduce the healthcare burden of administrative work and keep that to patient care. And then my second comment is about the confidentiality. And the submission requires extensive material and documentation, payer agreements that are extremely proprietary and confidential. So I would actually go on the side of having the general filing as confidential until there's more experience with what information is filed and how it could impact individual markets if this information is released. Thank you.
Ivana.
Little tutorial to start. It's Ivana. I know it takes a while, but I thought I would correct people before the Ivana thing takes off. So I also want to sort of piggyback on Joan's comments. I think it's easier to tighten the criteria or loosen the criteria if it turns out they're set too tightly than the other way around. And I think we don't know what we don't know. I'm also really concerned about having more markets like Monterey, where we have very few hospitals with extremely high prices, and they've gone out and they have purchased urgent care so that you now get fed into those hospitals because that's your only option. They're building more, adolescent behavioral health as, another way to expand access or feed into their hospitals again. And all the work that OCA is going to do to sort of control prices in the long run isn't going to help when, according to RAND, they're already paying close to 500% of Medicare. So I think that the administrative costs of doing all this due diligence at the beginning pale in comparison to the costs that we pay when we have highly concentrated markets with something approaching monopoly prices. So I'd encourage us to have the broadest criteria possible, and then if it's too much, we can always scale it back.
Thank you. Ken?
On the premise that it's always difficult to give something that you're going to have to take away, it'll be better if we start on a stronger end and loosen up if we have to. But my question is whether any retrospective study was done that would have estimated the number of filings that would have been required for notifications over, say, a prior year or two to get a sense of what kind of volume we're talking about.
Thank you. That's a good question. And we did do some analysis with one of our experts looking at various transactions of multiple types of healthcare entities over the last 5 years when developing the thresholds. And we have looked at other states. We have worked with states that are currently implementing and doing these programs, including Massachusetts, who's been doing it for a decade, and Oregon, who's just starting out.
Well, thanks. Can you give us a sense of numbers?
Can you clarify numbers of anticipated
Yeah,
transactions?
just the number of transactions, say the numbers of 25 million or more that would have required filing notification.
Yes, and our review, we looked specifically at revenue and size of entities in the transactions that we looked at over the last 5 years. And it was anticipated at that time that we would receive about 100 filings per year. But again, I would emphasize that that's the numbers. That's not the factors. So that's based on just the thresholds alone.
Okay, thank you.
All right, we'll go to Carmen, then Janice, then Parker.
Yeah, I want to echo some comments that were made, by Joan and Ivana. I think it's incredibly important that we cast a broad net right now in terms of trying to figure out what the transactions that are out there and how they impact patients, how they impact the healthcare workforce, and making sure that we get that information, because I think what's happening now is there's a number of influences on healthcare costs, healthcare affordability, and we need to figure out what those factors are. And I think it's really important to that OCA gets this information. One of the things that I think is really important that we haven't yet quite talked about is trying to get information on, I guess Ken mentioned it earlier, which is, what is going to happen when larger entities purchase smaller entities and the impact on the prices. Is there some way that we can make sure that OCA gets the correct information to understand how premiums, how deductibles, how provider networks, prior authorization, those types of things will change based on the conglomeration of entities, whether they're plans or providers. And I think that's really important, particularly in terms of assessing the affordability angles for both patients and purchasers, whether they're unions or other types of payers, and particularly how that may impact the state of California as the largest payer that we have for our Medi-Cal programs. And I think those are really important to underscore, which is why I think, just to emphasize that we should include things like MSOs and reporting for HPSAs, and trying to get all of that information together. I think, if we had a little bit more information about how we can address affordability side for patients, that would be incredibly important, which is part and parcel why the labor market review is incredibly important, because if we have transactions where there will be staffing cuts or there'll be cuts in services, which is both a loss for patients and a loss for those workers in those facilities, then, obviously healthcare costs will go up for both patients and payers, and people will just not get the care that they need. So I think those are all really important things that we should be considering, and that right now we need to make sure that we get as much information about all the transactions as possible. Thanks.
Thank you. Janice, and then Parker.
Thank you. I definitely want to echo what Carmen and Joan had mentioned about the importance of including the impact on labor, and also want to stress the importance of including these transactions, such as including technology. We represent a rural hospital that acquired an electronic medical record system. It didn't work out for them, and they spent millions of dollars on this system and had to purchase or go with another system, which heavily impacted our members. This is already a rural hospital that's distressed. They have an over-reliance now on contract nurses, which is obviously doubling, if not tripling, the costs on labor. And it is important that we have that overall review and impact on technology, and have this broad system so that we can understand what's going on. And these people also in rural areas that work in these hospitals are the people in the community that utilize this care. So I think it's really important that we focus on that. One question I did have is when if a transaction is not reported, what is the recourse for the healthcare entity?
It's a very good question, and I'm glad you asked it. So the office could refer that matter to the Attorney General, and the Attorney General would have the discretion, because there was non-compliance with the statute and the regulation, as to what the Attorney General would pursue. And it could be as much as unwinding a transaction.
Thank you, Parker.
Thanks. I wanted also to appreciate the struggle between how wide to cast the net, and I wanted to add a vote in there from the perspective of providers and ultimately patients. And as working in FQHC 10 years ago when I started, I used to brag when I was trying to recruit other residents to say, hey, okay, we get paid less, but we're doing what we like to call God's work. But really, what I used to be able to say is, we almost have a universal care system. I have 3 healthcare companies. I have the totally uninsured. We charge them $22. I have Medi-Cal, and I have the fortune of working in the partnership health plan area, which I think is one of the best health plans probably invented. I know there are very problematic Medicaid or Medi-Cal areas in the rest of the state. And then we have Medicare. Well, fast forward now with the vast infusion of Medicare Advantage plans, and now all of a sudden, if I'm not paying attention, every single patient I see, if they're in Medicare, could have a whole different pharmacy benefit and all of that. So it's become very complex, and kind of a testament to that last night. In fact, I was ruling out a preterm labor patient, 32 weeks. This can be a dangerous thing, can have horrible outcomes. And the end of the story is that she needed a medication on Friday afternoon that is required during her pregnancy. She has a certain history that needed medication, and that medication through partnership we send, and it goes through because it was already known and approved. What the clinician on Friday afternoon did not realize was this patient happened to not be on partnership and was on a private plan, and that required a pharmacy benefit manager and paperwork and 8 other forms. And so that patient did not get her medication, and she subsequently went into compromised medical state, and 2 days later, last night, my labor and delivery was in preterm labor. So it's just a case in point of, to the extent that we can really start to get a handle on all these other players that are involved that are really complicating and interrupting patient care. And as we know from a clinician or direct provider end, burnout is a huge thing. And one of the major factors in frontline provider burnout is all of this mess that is out there that is complicating the desire to take care of the patient. So to the extent that we can cast the net to start to get a better handle on what is going on out there, that's a vote for that.
Thank you. Sumana?
Thank you. I've appreciated all the comments and discussion here, and just one word on transparency. When it was brought up that a lot of these contracts are confidential and very proprietary, and we're talking about Monterey County as a case study. Would it hurt to know what hospital-based clinics are getting reimbursed and why they are many times more than a small independent practice like mine that has absolutely no cushion? Is that going to harm the system or harm affordability in general? I guess I don't see that. Thank you.
Thank you. Hector?
Yes, great discussion. Question maybe is something to trend. I agree with those who are saying we shouldn't include MSOs. They're really just processing claims and payments. They're not payers themselves. But there is something you may want to trend, which is as they get bigger, can they get to a point where they're actually monopolistic in their services and start changing the dynamic between the delegated model IPAs and their management services? Something to trend, I would say. The other is starting to see a really bothersome trend because of the critical shortage of behavioral health professionals, where we're starting to see public systems like county departments of mental health losing their employees to private companies who offer higher pay, convenient work because they can work from home. Most of these are virtual companies. And they're not acquiring that practice, they're just acquiring the employee, the workforce, passively in that sense. And I wonder if Joan or Ivana could give us some guidance on how to trend that, because that behavioral health company could become monopolistic at some point as well, while also depleting valuable resources from underserved communities.
Wow, that's a tough one. And I think that's exactly what we're here to struggle with. And I mean, as I was speaking to some of that getting at more granular data about the workforce, the more that we can do that, because statewide data can really mask regional shortages. And so the more that we can get at service lines and the expected impact on service lines of transactions, and understanding that if you're impacting a service line, it's impacting that workforce, and that the reason a service line may be impacted is because of the workforce. And so these are just so intertwined. Yeah, I think that's why casting that broader net is so important.
Thank you. Any additional comments or questions from the committee members at this point? Carolyn?
Thank you. I just wanted to reaffirm what's being voiced here. And I've heard a couple of times about OCA itself perhaps expanding its workforce in order to accommodate the load of reporting that might come through this loop as a result. I am 100% in agreement with that broad net. I live in a rural community. I live in a community that is losing population. 5 of the 8 counties we service have the fastest loss of population. And part of that is due to the lack of health care. It's just not there anymore. It's non-existent. You go to somewhere like Modoc County, where you have literally a population of 2 people per square mile. Lassen County, 5 people per square mile. Butte County, 14 people per square mile. You cannot keep health care because you don't have the population to do it. So some of the comments and thoughts that are brought to this table here, they're really serious. They're happening right now. And I really respect the fact that there are timelines put in place and we want to move forward. Our last meeting, we spoke about the requirement to keep moving and start doing something. It's just that we would be remiss not to really look at what is happening right now in terms of population and clinic loss. I'm going to Susanville Wednesday this week for a discussion about the closure of the clinics in our region. We have clinics that just can't make it. And that's not happening 2 years from now. That's not happening 2030. That's happening right now. We're missing something. And I can't just sit and listen and not really emphasize we are missing something right now. It's not just a long-term solution. We've got to deal with the here and now as well.
Thank you. David and then Tam.
I just wanted to follow up. I know I made the argument already that I think the scope of this regulation is so broad it's going to bring in too many transactions for reasonable review. But the example that one of the colleagues just mentioned of a hospital acquiring an electronic medical record and then having a difficult implementation and costly implementation, to me is a very good example of something where there's a competitive market for EMRs out there. Entities should make decisions about which they choose. But I think the notion that the government would be evaluating the pros and cons of a particular EMR decision, to me, just seems way out of scope for what we're trying to tackle here. So I would really encourage looking carefully at what kinds of transactions really should be evaluated and what should the private market take care of.
Thank you. Tam and then Ken.
Hi, thank you. Okay, sure. I wanted to comment on the definition of affiliations and appreciate the draft that excludes clinical trials and graduate medical education. I would encourage the office to broaden that exclusion because clinical trials is just one form of clinical research that takes place. And so we want to be able to include in the exclusion other forms of clinical research. And then second, graduate medical education specifically refers to training of physicians after medical school. And at least for the University of California, we train a number of other kinds of healthcare providers, including dentists, nurses, optometrists, veterinarians, and public health professionals. And in order to do so, we have affiliation agreements with a number of a variety of training sites across the state, including community hospitals, public hospitals, the VA, FQHCs, and other settings. And so I think that those kinds of training agreements should also be excluded from the definition of affiliation. Thank you.
And just a quick question to David's point. What I understood about the comment about the EMR purchase was if it blew up and it represents a substantial additional cost to the entity, should that cost be recognized as any part of this process? In other words, it was a management misstep. And I just want to be sure that that cost wouldn't be factored adversely to protecting purchasers and consumers from these transactions. That make sense? Well, then maybe I misunderstood the original comment.
I think we've heard a variety of perspectives about whether transactions like a health system buying a medical records system should be something that's under the purview of the cost of market impact review. So I think it was helpful to hear Janice's specific perspective and example, and David disagrees that we should be in the business. So we're taking all of that into consideration. I think you're adding on to it, Ken, to say that, yeah, I mean, if a clinic buys a system and it goes bad, that there's an impact on patients and there is a contracting and cost and affordability impact. So we have a lot to balance.
So Ken, I was looking at in the healthcare services, what services defined in the regulation. It includes technology such as EHRs. So I interpret this as an entity that's larger than 25 million who is inputting an EHR. We might consider that transaction as something to need to be reviewed.
Okay.
That was my concern.
Thank you for clarifying.
Sarah.
I just wanted to make a brief comment on electronic medical records and that it does impact the working conditions of healthcare workers and the care that's provided. And so I do think it's very important. I deal with using them every day at work, and the costs of them can impact the amount of care provided, and also the usability can really play a role in how quickly a clinician can use it and move on to the next patient or client.
Thank you. Go ahead.
Echoing what Sarah just spoke about, I think for EHRs, it's really important that we are able to capture some of these transactions because, you know, I think the growth of tech and tech's interest in healthcare is really important for OCA to be able to monitor in terms of specifically when we're issues of algorithmic bias and clinical decision-making tools. And if there are histories of EHRs or clinical decision-making tools having that type of impact, which can impact provider decision-making or denial or provision of care. I think it's really important that information gets captured. I think what some of us were saying earlier, which is let's cast a broader net and figure out what is actually happening with all these transactions, and are they influencing how decisions on care are being made, and the costs of healthcare.
Thank you. We'll now move to public comment. We'll recognize members of the public for comment on this particular agenda item. Those in the room, please step up to the podium. Those online, please raise your hand. Please note that while the advisory committee is committed to communication and transparency, advisory committee members and staff will not be responding to public comment. Additionally, the committee may not discuss or act on any matter raised during the public comment period. Please go ahead at the podium.
Jane? Oh, I don't know if you can hear me, Jane. Oh.
Yes, Sheila?
Oh, yes. Before we start public comment, I just wanted to wrap up and express my appreciation for all the different perspectives. I really appreciate that this committee has shown their engagement and their passion and shared their knowledge. The comments are very helpful. And I would just like to say that, the heart of our statutory mission is to provide information that is helpful to the public. So it's very helpful to hear your remarks, to hear your concrete examples and your thoughtful suggestions, and see how that fits within our mission and what we're trying to do. Thank you very much.
Thank you. Moving to public comment.
Beth Capel on behalf of Health Access California. Just a few points, and we have submitted written comments as well as testified at the board itself. The point of this review process was, in fact, to get an overview of what's going on in healthcare, and it was intended to cast a very broad net. It is not intended to triage or narrow the transactions that are looked at, in part because, as has been said, we don't know what's going on in this market. We suggested that the office look at the threshold the Attorney General uses, which is $3 million for nonprofit health facility transactions. We also looked at what was the size of entities that were involved in various transactions. With respect to healthcare services, the definition is very good in terms of physical health, but does not focus as much on behavioral health, which is obviously such an important area. Next, we think it is essential that the office have the time and the resources that it needs to review what may in many instances be multi-billion-dollar transactions. And so any effort to shorten the time or undercut the resources is something we would oppose. The premise of the law is that what is given to the office is public information unless it is clearly held confidentially and has not been available publicly. And we appreciate the regulations on that point. Certainly there is information that is not publicly available and has been maintained confidentially, and the law recognizes that as well. We seek the opportunity for public comment and also for public meetings.
10 seconds.
Yeah, with respect to benefits, we would like to see evidence that the asserted benefits will actually occur as opposed to promises that are meaningless. Thank you.
Thank you. Looking online for hands raised, noting that we have an estimated 52 virtual attendees. Seeing no hands raised at this time, inviting individuals in the room to step to the podium.
Hello, everybody. Ben Johnson with the California Hospital Association. Appreciate the additional opportunity to provide public comment. It's been a really robust public process, and we're really pleased with that. We've previously shared our substantive concerns on the regulations, but just want to add a couple of points here. First, we don't necessarily agree with the assertion that the intent of the legislation was to capture nearly every transaction that occurs in the healthcare market. In the opening paragraph of the legislation, it states that the office shall prospectively analyze those transactions likely to have a significant impact on the market, and we think that the rules can be significantly narrowed and tailored to fulfill that statutory prerogative. If finalized as currently, the notices, we believe, would gum up the office's operations as well as healthcare entities' own market operations and just their ability to deliver care to their patients. We are particularly concerned with the overbroad definition of transactions that's going to capture many transactions in the course of ordinary business, including contracts to be an in-network provider with a health plan, the EMR sign-on issues that have been raised today, as well as down even to when it comes to serial transactions, repeated letters of agreement to serve an individual patient for a health plan and a hospital. So there are many areas in which we do not believe that these regulations are workable as currently. Beyond just the definition and the scope, we do believe that the timeframes are overly long. They would send entities would have to wait 250 days or more to consummate transactions if they're subject to a full review. Also concerned that there are no reasonable assurances that the fees will not be excessive when charged to entities, and we don't believe that the criteria for waiving a review are adequate and give enough assurances and allow entities to plan whether or not their transactions will be delayed by maybe a year or somewhat less. So thank you very much, and look forward to continuing to engage.
Thank you. Looking for hands raised online, seeing none, inviting individuals in the room to step to the podium.
Hello there. My name is Harvey McKeown. I'm from the NorCal Carpenters Union. I really have appreciated the discussion this morning. I've spoken on these regulations before. And, generally, we welcome the fact that this is a broader conversation about market power. We can speak to, what we experience as a payer in the market. Our main provider is Kaiser. Kaiser has about 60% market share of the large group market, has about 30% in the small and individual group markets. So how does that market power translate into consumer outcomes? Well, I think it would be remiss to not point out that Kaiser is now proposing significant premium rate increases in the large group market, where it has the most market power, and it is proposing significantly smaller premium rate hikes in the small and the individual group market. So there is a question here about how market power translates into consumer outcomes, and as has been made, a point that's been made by previous speakers is we don't know what's going on in this market fundamentally, but we would like to learn more through this process. The other point that I'll make is, a merger or a transaction that's been raised a number of times is the Geisinger merger. And we would really like to understand better this merger. One of the ways that we would posit that Kaiser's acquired some of the market power that it has is through its status as a charitable trust. And it now appears that it's intending to use charitable assets to effect a merger across state lines at no apparent benefit to California consumers. So we welcome the discussion. We're really happy to be engaged. And thank you for taking our comments on board.
Thank you. Seeing no hands raised virtually, looking back to the individuals in the room.
Hi there, Andrew Kiefer with Blue Shield of California. It feels a little odd since we have a representative on the board here, but some of the comments have sparked what I would take as an educational opportunity for us to put in context some of the purchases that would be subject to the review in this. When we, as a supporter of the original law, as Blue Shield of California, sat in every single room as the discussions were ongoing, there was clear intention to capture the activity around mergers and acquisitions where organizations are buying or partnering with in a manner that is affecting market behavior and pricing. There wasn't a discussion about whether or not an investment from Blue Shield into a health information technology or purchasing technology for providers' offices to share clinical information would be subject to it. The beauty of the law that was passed, however, is those transactions are accounted for. And what I mean by that is the charge of the Office of Healthcare Affordability is to hold my company and the rest of the healthcare industry accountable for cost over time. What that includes is a review of how we're performing against cost targets that will be established. So if we mess up and purchase a bad electronic health vendor, record vendor, and there's a failure there and it affects our cost, that is subject to our filings with this department. Those are captured. There is opportunity for influence by the board and by the state to ensure that we are making sound investments. But to subject every single transaction is both out of scope of what we believe was originally included in the law and also redundant with the charge that the office itself has. So with that, I would cede the rest of my comments to my representative on the board for the company. And I appreciate your time and your diligence here.
Thank you. Seeing no hands raised virtually at this time, turning back to individuals in the room for public comment. Seeing none, we are right on time for lunch. We will take a break from 11:57. We will reconvene at 1 p.m. All right, good afternoon. It's 1:01 p.m. We'll now call the meeting back to order. For the purposes of the record, we will do a roll call after lunch. Please remember to speak into the mic when the light is green. Joan Allen.
Present.
Barry Arbuckle.
Present.
Eliza Arjoyan. Stephanie Klein. Present. Carmen Comsty.
Present.
Adam Daughtery. Parker Duncan Diaz.
Present.
Hector Flores. Sarah Gavin.
Present.
Stacy Haratzes.
Present.
David Joyner.
Present.
Ivana Krasinovich.
Present.
Tam Ma. Carolyn Nava. Yeah, thank you. Mike O'Day.
Here.
Janice O'Malley.
Here.
Sumana Reddy.
Here.
Yolanda Richardson.
Present.
Karen Savage Sangwan. Andrew C. Sarah Stroken.
Present.
Ken Stewart. Susan Usage.
Present.
Sorry, Suzanne. Yvonne Wagner.
Present.
Renee Williams.
Present.
Anthony Wright. Abby Yount.
Present.
All right, noting that we still have a quorum. We will now move into the part of the program on total health care expenditures. I'll turn it over to Vishal Bhakani.
Thank you, everyone. I hope everyone enjoyed their lunch. Before we dive in, I do want to make some notes on logistics in terms of the slide formatting. You'll see, similar to last time, we'll have a blue arrow, a figure with blue arrows on it, and that's when we'll prompt the advisory committee members for specific questions, and that denotes areas where the advisory committee provides input or recommendations based on statute and other areas as requested by the board or OCA. And then I also do want to note in terms of time management, we do have 3 distinct topics for total healthcare expenditures this afternoon. The first is risk adjustment. The second is our draft decisions for total healthcare expenditure data collection for the baseline report. And the third topic is our spending target methodology, which will discuss some initial considerations for economic indicators or population-based indicators not number value, but in terms of considerations of other indices we could look at to set a target. So that's our third topic. But I'd like to suggest that we spend the bulk of our time together on that last item, since the spending target, that's where a lot of the action is going to be, and how healthcare entities will be held to that. But that requires that we don't get slowed down too early on the first two items. So I'm going to ask that our facilitator note when we're at 20 minutes for each of those first items, and then we'll see where we're at in terms of moving on towards these other topics. And then, so we could move on to the next slide here. So during the June Advisory Committee meeting, we provided introductory information on healthcare spending targets, including taking a look at the experience in Massachusetts in terms of their Health Policy Commission, which was established 10 years ago. We reviewed California's spending target development timeline in terms of data collection and reporting. We'll be revisiting that today as well. And then we discussed the measurement of total healthcare expenditures in California. We begin some discussion of spending target program adjustments, including risk adjustment methodologies for reporting THCE. We didn't get to go as far as we can on the issue of risk adjustment, so we are going to return to some of that shortly. And next slide. So in terms of today's discussion, we'll continue discussing risk adjustment. We'll be discussing how to measure healthcare spending of health plans and provider entities. And then we're going to be reviewing the major draft decisions for collecting 22 and 23 THCE data. So this is data based on, for the baseline report, which is a snapshot of spending before the targets take effect. And then we'll discuss the process and timeline for regulation, promulgation, and then we'll do an introduction to setting the statewide target. And I'll be introducing Michael Bailey to cover the topic of risk adjustment.
Good afternoon, everyone. Nice to see you all again and to meet some of you for the first time. So as Vishal said, we're going to revisit risk adjustment, which we talked about just a little bit at our last meeting. Before we start, I thought I would talk about exactly what are we adjusting and why are we adjusting. So just as a reminder, the spending target is a goal, an objective for how much per capita spending in the state will grow over the course of 1 year. So what we are considering adjusting with risk adjustment is assessing for a health plan or a provider organization, how much did their population change in 1 year? Okay, we are not considering how to compare health system A to medical group B and the differences in their per member per month spending. That's not what we are adjusting for. We're just trying to consider if Barry's organization had a population it was serving in 2021, did that population change a lot over the course of 12 months? And if it did, do we want to adjust for that so that when we are measuring, and I picked out Barry because he had a lot of comments that he submitted on this topic after the last meeting. But over the course of a year, if the population changed a lot, do we want to take that into account when we measure per capita spending for memorial care? Okay, that's what we're talking about, right? Is that clear? Any questions about that? All right, I'm assuming no questions means I was clear. If not, feel free to ask questions. Okay, so OCA's enabling statute says it shall establish risk adjustment methodologies for reporting of total healthcare expenditures, and it should take into account the impact of perverse incentives that might inflate the measurement of population risk, such as upcoding. Okay, that's the statutory language. So we talked at the last meeting about OCA's contemplated approach of using age-sex risk adjustment. And some of you expressed interest in talking more about that topic at this meeting, and so we will do so. So I'm going to cover a little bit of the content we did at the last meeting, just as a reminder, because it's been 3 months and some of you weren't even at that meeting. So what is risk adjustment? Sometimes it's referred to as health status adjustment, and it's a process whereby you modify an assessment of performance. It can be for spending, it can be for quality, for other aspects of performance, by applying a mathematical adjustment. And it can take different forms. It's often going to be a calculation that looks at the characteristics of the population and how they change. And so there might be some multiplier to say the population became higher risk or the population became lower risk over time. There are other ways of measuring or of conducting risk adjustment in quality. There are observed to expected ratios. But for our purposes, where we're talking about spending, we're really talking about how to address per capita spending amounts. I will note that risk adjustment is commonly applied in contracting between payers and providers to account for population characteristics, and not just changes over time, but in the absolute population being served. All right, so that's a little background. So there are states that have previously implemented spending targets that have experience from which we can learn. Okay, sometimes it's best not to be the first one to do something. So I'm going to share with you a little bit of the experience of a couple of the earliest states to do cost targets, or spending targets, and what they learned. So Massachusetts began studying very early in their implementation of their spending target that risk scores were growing quite quickly. And so their spending target became effective in 2013, a decade ago. And so they analyzed spending growth, and they found that they could verify only a small percentage of the spending growth when they looked at independent indicators. So they looked at age and sex, they looked at disease prevalence, they looked at average length of stay in hospitals, they looked at use of ICUs. They couldn't verify using other measures the rising risk scores. And so ultimately, they moved to a recommendation that they remove all adjustment when they measure spending growth over the course of a year. And again, I just want to emphasize, we're talking about spending in the course of a year. Okay, over the course of a decade, populations change a lot, but we're just talking about over the course of 1 year. Another example, this one's from Rhode Island. So they found in their very first year of having their spending target that payer risk scores grew 4.6% in 1 year. That 4.6% had the practical effect of raising their spending target from 3.2% to 6.4%. Okay, so everybody meets 6.4%. Did everybody meet 3.2%? No. So the impact of the rising risk scores effectively was to raise the spending target and quite dramatically. And so as a result, Rhode Island, which started by using risk scores that looked at patient diagnoses, moved to using only age or using instead age and sex. And in fact, since that time, all the other states listed here also decided to adopt age-sex risk adjustment because of concerns about inflating scores if you use diagnoses on claims. And in fact, in Nevada's governing body, like Massachusetts, recommended no risk adjustment. Okay, so that's a little experience from elsewhere. So there are fundamentally two options for doing risk adjustment. Clinical risk adjustment is what Rhode Island was doing, and that looks at diagnoses accumulated over time for individuals on claims to assess their health status. These clinical risk adjustment software packages, or groupers, they're called, they're actually pretty good at projecting future spend. They explain about half of the variation in healthcare spending. Now, you might say half, that's not very much. It's actually pretty good because a lot of healthcare spending is random. There are events where people have no risk factors and all of a sudden they become really sick. Those can't be predicted. So the fact they explain a lot of the spending at 50% is pretty good. The problem is that is the application of diagnoses on claims is subject to strategic efforts by provider organizations that get, and insurers that get rewarded for having more diagnoses on claims. So they're both good, but they're problematic. Okay, age sex factors, just look at the fact that we know that actuarially an adult over age 50 is going to generate higher spending than an adult age 40 to 50, okay? Because we know as people age, that the burden of illness grows, and so does healthcare spending. Okay, we know that women of childbearing age are likely to have a bump in their spending. Okay, we know that very young children have a ton of care, and then as they get older, their utilization drops. So that's all that age sex captured, but over the course of a year, biggest change in a population is probably that it's going to age a little bit. Okay, so I know Barry, Stacy, Sumana, Hector, you guys all had comments after the last meeting about risk adjusters. I would say that the states that have opted for age-sex risk adjustment before California did so thinking, boy, we really wish we could use clinical risk adjustment, but there are just a lot of problems with using it. And so we don't love age-sex because we know it doesn't explain everything, but there are too many problems with using clinical risk adjustment. Okay, so that's how they arrived at that conclusion. Again, a couple of states said we're not going to do any adjustment at all, but that's how they got to where they did. So let me pause. That was both a refresher and some new information for some of you, and ask for any questions that you might have or comments.
Can you speak into the microphone?
Just that desire to take into account, geography, other demographic, social determinants. I understand that this may be the simplest
yeah. So remember,
way, but
we're not doing this to compare geographies or populations. We're only using the adjustment to say, did the population served by a large provider organization or a health plan change substantively over the course of 1 year? If instead we were to say, let's compare spending associated with one patient population and another, or one geography and another, then we're talking about a very different application of risk adjustment. And I would say, if you want to make comparisons, including between provider organizations, you really can't do that without thinking about risk adjustment, because if my target market is, as a provider organization, are people with chronic illness, and yours is not, I'm going to have much higher spending than you do. And so in that case, if I want to make that comparison, I really have to find some way to do risk adjustment. But that's not how we're applying risk adjustment here. We're just saying, is your, I know you have a small practice, but let's say it's a super large practice. Let's say you serve 50,000 patients. Did your patient population in 2022, from January 1 of 2022 to December 31st of January of 2022 change significantly in terms of its health status?
I see. And yet I could see impacts because programs drop or are created based on, you could just take age and gender and ignore those other factors and make your and change.
Yeah, so age and gender is imperfect. I don't want to suggest that it's perfect. It's not. It's just that the alternative isn't a good one.
Thank you.
You guys want to handle all the hands?
Yeah, absolutely. Go ahead. I think we have David, Hector, and then Adam.
David Joyner, Hill Physicians. So I understand, I don't necessarily agree, but I understand the argument you're making, but I think, and maybe this is my ignorance, I didn't know that we decided or in this effort, there would only be a single rate increase set statewide. I was assuming that there would be potential for differences by region. I also assumed that you might not set the same trend increase target for all types of providers. So to my mind, if you say, well, we're going to have one statewide number, I think your argument I understand. But I think if we think that there's a chance there's going to be different targets by geography or different targets by type of provider, I think then it's much more problematic not to have some kind of clinical.
So David, initially there's just one. The statute lays out language that anticipates that there might be more in the future, but initially there's just one statewide target.
Yeah,
for all provider types?
For the whole state, for everything.
Yeah, David, the first few years of the program, there's going to be a statewide target. And as OCA gains experience, we do plan to implement sector targets, which is in the statute. And sectors need to still be defined by the board on what those sectors could be. They could be, the statute itself gives a few examples, such as fully integrated delivery systems, geographic regions, or individual healthcare entities. So that's the idea of the sector targets, to move away from a kind of one number for everyone to a more tailored approach. But the statute itself lays that out in the future. On or before June 1st of 2027, the initial sectors would need to be defined. So we could do it sooner because it does say on or before. But we do recognize we need to kind of build that experience of working with the data and so on. And then the board would have to set sector targets for particular entities or geographic regions.
So I know it's a futile effort to try to argue against what's in the statute, but if part of the goal here is to set targets that are believable, accepted, bought in by actors in the industry who would strive to reach them, to my mind, not trying to make an effort to adjust for geography or type of provider just sets you up for a situation where people say, I don't really buy into this target because it really doesn't reflect the reality we face. So I hope it'll be sooner rather than waiting till 2027.
Thank you. Moving to Hector and then Adam.
Yeah, just had a question about, or a comment about the going back to risk adjustment. One of the things that physicians, nurse practitioners, PAs, advanced practice clinicians are notorious is for undercoding the services they provide, right? Insurance companies knew that for a long time. They didn't tell us, right? Not because you're sitting here, but they didn't tell us because we were making money for them. But what I've seen as a value to risk-adjusted scores, for example, for Medicare Advantage, is that we're finally getting really good data collection because the clinicians are in the best position to understand the complexity of a patient. And if we don't do that, we're going to miss a huge opportunity to help us do better science in the future beyond just age, sex factors.
Yeah.
I think that would be a critical loss.
Well, so all the economic incentives, Hector, in Medicare Advantage to do that coding, they're not going anywhere, right? Those are still there. We're just saying that for the spending target, we're not creating an additional incentive, which frankly probably never be as strong as the contractual incentive for Medicare Advantage and other contracts.
Right, and I'd like to see it, across all payer types. So in our practice, we do that with the Medicaid population, the commercial, the covered California, because we want to get a sense of how overworked our providers are if they have highly complex patients. Mm-hmm. And then we make decisions about scaling back our growth as a result of that. I'd hate to lose that in this eagerness to just go to age, sex.
Yeah, I just don't think that the spending target is going to counter the already existing economic incentives to be thorough in coding.
Adam.
So one of the primary goals is health equity for all Californians, and I don't, I don't think age, sex achieves that goal. For many of the comments already said today, We have precedent. We have the Covered California methodology. And I don't think necessarily that comparing to other states is quite as applicable here, just given our sheer size and uniqueness that California is. So because it's hard, I understand that there is some hesitancy to clinical risk. But again, if we're going to do this right, it has to be from the start. If we can't apply it until a couple of years down the road, given specific industry spending targets, that's fine. But I still think wholeheartedly we need to do it.
Thank you. Andrew?
Yeah, so I guess, I have two minds on this one, right? Because age gender really does have pretty lousy predictive power. But just given the incentives, right? You go back to incentives, right? What are we trying to do here? And then you see examples, outside California, and I realize we're not Massachusetts, we're not Oregon, we're not any of these places. But I think, for this very specific purpose, right, which is really a big population, right? Big population year over year, how much the demographics has changed. This probably works. I think the intent is to use age gender by line of business, right? We'd have different ones for commercial versus Medi-Cal versus Medicare, right? So probably we'll capture a little bit of the social determinants there. Very imperfect. But I keep going back to incentives. What are we creating? And I think I guess big populations for this very, very narrow application, I think age gender probably works, as opposed to introducing more incentives to code. And that actually includes administrative burden as well, right? So that doesn't come free.
Yeah. I'll also add, I just don't think we should expect to see a big change in the health status of a population in 1 year.
Especially big population.
Right. And we're only measuring large populations.
All right, I'll note at this point we have used our 20 minutes allotted for this topic. I'll let you make a determination.
Michelle, anything else you want to say on this topic?
Does anyone have any kind of burning thoughts, additional thoughts before we move on?
All right, we'll move on to the next topic.
Okay, thank you everyone for your thoughtful conversation. So the next topic is one that the board discussed last month, and so we want to share it with you. And it was really an informational item because it's a question that OCA is still working on. So the issue is identifying both which health plans will be required to submit data and which provider organizations will be measured when the data are submitted. So first, I'm going to talk about health plans. And the criteria that were used was to focus on the payers that represent the most spending in the state. Two, to not collect data from payers that are too small to contribute to statistically meaningful measurement of healthcare spending in California, because it's both administrative work for them, but it's also administrative work for the state. A gigantic health plan and a tiny health plan in terms of membership, it's the same amount of work to analyze their data. It's the same amount of work to prepare it. And so three, we want to be sensitive to the administrative costs of data submission, collection, and analysis, with the objective, and balancing that with the objective of data completeness. Michelle?
Next slide. So this is, based on those thresholds, based on a threshold of at least, hold on, so I want to cover OCA's considerations for measuring total healthcare expenditure at the plan level. So we're proposing at least a 48,000 covered lives threshold for any market. And if you hit that 40,000 threshold, you would be required to submit THCE data for any market you participate in, which could be the three markets of Medicare, Medicaid, and commercial. Under this approach, nearly all Medi-Cal plans will be required to submit THCE. There's a few specialty plans that are listed in parentheses that have very low enrollment and they would be excluded. So under this approach, with this 40,000 covered lives threshold in any market, we would capture nearly 99% of the commercial market, commercial and Medi-Cal managed care markets, and the majority of spending in the Medicare Advantage market at 97%. So the next slide just covers OCA's internal analysis of health plans meeting the 40,000 lives threshold for calendar year 2022. So this analysis is based on data that's put out by California Healthcare Foundation, which compiles data from DMHC and CDI health plan enrollment. So by commercial market, we have about 14 plans that would meet this threshold. Medi-Cal, there would be about 22 plans, and then Medicare Advantage, we would capture 12. And then you'll see some of the same names in each of the markets, such as Anthem, for those that participate in all three. So this is just, our snapshot of 2022. We're going to have to look at this based on 2023 enrollment, just to make sure there aren't any new plans that came into the market. For the baseline report, these would be more or less, these are the entities that would be submitting data. And moving on to the next slide, one back. I think we're a few slides back.
Yeah, I don't know how I did that.
Okay.
Sorry about that, Michelle.
No problem. Any questions about OCA's proposed approach for health plan data submission?
Yeah, Andrew, and then Hector.
Yeah, just a quick question, and I don't know if there are any TPAs or self-administered plans that have 40 or 50,000. I'm just trying to figure out what we're missing, right? I think, the 14, you get the lion's share. I don't know if it's 99%. I'm just trying to think through, and is there a significant chunk of data out there that OCA is missing?
So, yeah, this is based on the health plan enrollment filings that plans do to DMHC, which would include, for commercial, it would kind of break it out by small, large, individual. But we're just kind of looking at commercial total, not necessarily fully regulated versus self-insured. Or is that your question?
Yeah, I'm just thinking more of self-funded plans, right?
Self-funded,
That are,
okay.
TPA administered, not by a health plan. Or
okay. I understand that.
There could be significant lives out there.
Yeah, that is a universe of coverage that they don't use a TPA from an existing carrier. OCA would at this time doesn't intend to go directly to those carriers to collect data because there's not an easy way to identify them in terms of the ones that we already know that participate in the commercial market. If there's an employer out there that's self-insuring, we wouldn't be getting the data.
Andrew, we did look at this, and we don't estimate that there are any that are large enough. I will say our experience in looking at this in other states, including some states that actually require TPAs to be registered, so the universe of them. There tend to be a lot of them, but they tend not to have a large number of covered lives. Most of the self-insured employers, especially the larger ones, use the big carriers. And in fact, if you look at especially the national carriers, their business is almost all TPA business. So that's where the big volume tends to be.
All right, we'll go Hector, Ken, Suzanne. All right.
Question about the previous slide mentioned Unlock as an example of a health plan that would be excluded. And I'm familiar with Unlock as part of the PACE program, the program for all-inclusive care of the elderly. I don't know their financial performance, but I'm on the board of the LA County Medical Association, and last year I got a prospectus from private equity about investing in PACE programs. And I'm thinking anytime private equity is looking at something, there's money to be made, right? And so I started looking around some of the PACE programs in Southern California, and they're very profitable. And as we see the aging of the population continue to grow, and we know there's a lot of housing insecurity among people who are aging, who are not necessarily low income, but they just don't have the security for housing, there's going to be a demand for these types of programs, and they're going to grow. So maybe something that you want to trend, if not include currently, is what these PACE programs are doing and how quickly they're growing and what impact they could have.
Thank you. We'll go Ken, Suzanne, and then Sarah.
Okay, thank you. Andrew, to your point, coming from the HPD standpoint, on the ERISA plans that are self-administered or have somebody else paying their claims, we're going to be making a concerted effort to get them to independently authorize for the submission of their data. And in fact, where the health plans are paying their claims, I know HCI has been talking with the health plans about reaching out to their ERISA plans for authorization to include their data with what they're mandated to be submitted. So I think our intent is that we'll capture a good amount of that data.
Thank you. Suzanne, Sarah, Eliza, and then Barry.
I think I'm just expanding upon and saying ditto to what Ken mentioned, is that I think it'd be pretty easy, because I think you're right that most employers are self-funding, are using the network, but a lot have now shifted in the past 5 to 10 years to a third-party arrangement. And so I think just asking the health plans to do the authorization is great. So I'll just echo that.
I think I brought this up last time too, but I'm just curious about how county short Doyle behavioral health services get captured here too. Substance use treatment, specialty mental health, all the costs associated with those.
We have been meeting with DHCS since shortly after the statute got passed to try to figure out some of that financing. So we are looking to capture a lot of the Medi-Cal supplemental payments. Vishal, I haven't been in those meetings. Is there anything else you want to add?
Yeah, we are doing an inventory of those various payment streams and then looking at the county behavioral health carve-outs, organized delivery system, and then the short Doyle mental health to capture that spending.
Thank you.
Eliza and then Barry.
Have we contemplated actually defining the data, meaning in California, unlike other states, there's quite a bit of delegation and quite a bit of capitation payments that are made above and beyond the claims component. And so are we looking at encounter data submission? Specifically, what type of data are the health plans going to be required to submit, and what is the frequency of that submission?
So, Eliza, we're going to cover that a little bit later.
Okay.
Okay. Thanks for the question.
On the data that the health plans will submit, I assume that will include among the kind of the medical costs, also the G&A and profit from the health plans?
Health plan admin costs and profits will be included in the total healthcare expenditure collection.
That's what I thought. Given that the vast majority of lives on your list are from multi-state health plans, and considering the economic principle that money is fungible, it can be moved anywhere. How will we control against them moving money out of California, if we will, expense into other states in these multi-state single corporation companies?
I don't have an answer for that, but are you just talking about the health plan admin cost portion or the spending portion on claims for
claims? I think that could be refined.
Yeah,
but
okay.
The G&A and the profit can be moved anywhere.
Okay.
They could wildly make much more profit in Alaska than California in 2025 than they did in 2020.
Yeah, we're at least from my understanding of the MLR filings, it is going to be at the carrier level. So we could definitely take that issue back just to talk to our colleagues at DMHC and CDI to make sure that, yeah, I don't anticipate the spending target program itself creating that incentive to shift money around, but I do want to understand kind of the admin costs and profits that they report. Is that specific to their California business? Yeah. Yeah.
All right, noting we've got about 7 minutes left on this topic. Of the 20 minutes, we have Ivana and then Adam.
Maybe I'm missing something basic, but on that last point, isn't it the admin spending is what we end up paying? So that's how it shows up. And if they want to shift it to Alaska and we don't have to pay for it, isn't that okay?
Yeah, in concept, that sounds like it would happen that way, but I'm not. Yeah, we'll have to talk to our colleagues at DMHC to really understand that.
And in that same vein, considering and capturing potential gaming of unpaid claims, downcoded claims in arbitration in the IDR or otherwise, we're seeing increasing concerning non-payments, especially on the ED side that we've had to go to DMHC for assistance with. So anything on that front to anticipate in the future.
All right, I'm going to press this on because now we're probably down to 6 minutes, right? Okay, so that was plans. I want to talk about providers. So we're going to be ultimately measuring performance against the target for a variety of different types of providers. And I want to distinguish two classes. The first is systems, physician organizations, FQHCs, to which we can attribute spending through a primary care relationship. Okay. The second category, hospitals and specialists. I'm going to talk today about the former, the method for doing the latter is a topic for another meeting. So we have been talking internally, and we talked with the board in August about developing methods for measuring spending where we can attribute through primary care, either directly or inferred. So as a reminder, what are we measuring? We're measuring per capita spending growth over the course of 1 year. And we are asking payers to submit aggregated data to do so. Liza will talk exactly about what that is in a few slides. And we are measuring total medical expense, which is claims-based payments, non-claims-based payments, and the member obligation. So OCA has been working on creating rules that can be used as guidance to payers when they are submitting information on spending at the provider entity level. Okay, this is the attribution, and we have been testing both direct methods. A direct method is I, Michael Bailiff, picked Hector as my PCP. Hector is part of ACME FQHC, so my spending belongs to ACME FQHC. Inferred is when we don't have a clear line of sight between an individual because they are not in a product where they picked a primary care clinician. And so that's what we've been talking through and are continuing to talk through so that ultimately OCA can report on attributed spending for large provider entities. So there are some challenges in doing this work. One is we don't have a provider directory that says that Dr. Smith belongs to Acme Medical Group. Two, we know that there are individual clinicians that have multiple relationships with provider organizations and multiple contractual relationships. Sure, I'll be in your contract for this product. I'll be in your network for that product. Okay, that makes all of this challenging. And the health plans have difficulty drawing lines sometimes in these relationships. Okay, so those are some of the issues that we are wrestling with. Knowing that Jane's probably telling me we're down to 1.5 minutes, I'm going to go to Vishal to talk about the next couple of slides. you want me to cover it, Vishal?
I got it. So OCA is doing some work on engaging stakeholders on attribution. We have some work with health plans and providers on approaches with the goal of minimizing spending minimizing spending that is attributed. We've been meeting with a group of commercial and MA Medicare Advantage plans to discuss the issue of primary care attribution. We've begun to meet with the Medi-Cal managed care plans. And then we're also meeting with providers to discuss issues of attribution. So in terms of the next slide of our proposed approach, we're considering attributing spending to provider entities through primary care relationships as follows. The first one is direct relationships established through member selection of a PCP provider. This is most common in the HMO market as well as Medi-Cal managed care. And then the second approach, if we're not able to do it through the first, we would infer a relationship through plan analysis of claims using plan-driven parameters, such as if they have contracts that are used in value-based payment contracting and OCA-defined parameters to capture members whose care is not paid for through capitation or value-based payment arrangements. So the second step that we've listed here is it's in the PPO market with fee-for-service lives, we expect more of a challenge with primary care attribution here. And we're working through our stakeholder process, including the board and advisory committee, to get input on any attribution methodologies, any pros or cons associated with any approaches. And having worked through the first two steps, we do expect there to still be some level of unattributed spending. And moving on to the next slide, we just want to get input from the advisory committee on this issue, and as well as if you have any questions on the topic.
All right, we'll start with Parker and then David.
With the caveat that this topic's new to me, but just a couple things that in the world, I don't directly deal with these, but one question's about workers' comp and where that fits in, because that's a huge cost to a lot of people, and I don't know how you're going to capture those costs or whether that's already qualified, accounted for. And the other one is what I consider the auxiliary, if you will, healthcare system that is kind of all the other things outside the hospital and the primary care office. And that includes the chiropractor and the acupuncture and the natural path and all of those, the vast majority of which in this state are still largely cash pay, maybe with part of your copay or an extra like health spending account. But I would be curious to see, are we interested in that value, and does anyone have any idea how much is spent in that venue?
Yeah, I could take that, Parker. So for our approach would be to measure covered services. So the member does need to be in a health plan, whether that's commercial or Medicaid or Medicare Advantage. So we would only be reporting spending on covered services. That could include claims paid to providers or other non-claims-based spending. So we wouldn't be capturing cash payments from consumers simply because there's no comprehensive source for us to capture that. And then regarding your earlier question about workers' comp, that's also outside of the scope of OCA as well, because it's not within the context of a health plan. And that would also involve OCA having to work with several carriers that are distinct from health plans. Does that answer your question? Okay.
Great. Noting that we are at time on this topic, we'll go to David and Hector.
we have some experience at Hill Physicians from PPO attribution methodologies, and I just wanted to mention a couple of potholes that I anticipate you'll run into. One is sometimes you can get patients attributed to urgent care providers who appear as primary care providers in directories, but they're not really taking care of the whole care of that patient. So I would be very careful about that. Second issue is some primary care physicians sometimes will be medical directors at skilled nursing facilities. And so you can inadvertently get a large number of very sick patients attributed to a provider, which might make them look very high cost, but it's because they're not serving a normal primary care population. They're serving a very sick population. Final thing is you haven't said if you will be attributing to specialists. If you do so, that is also very tricky. Sometimes some people have chronic illnesses and they don't really see their primary care physician. They're only being cared for by, say, an oncologist. So you risk leaving that out, but if you include it, obviously their profile of expenses are going to be very different from a typical patient, being managed by a primary care physician.
Yeah, thank you for flagging that, David. We did, in some of our provider engagements, that has come up about when someone gets a cancer diagnosis, they kind of move on from their PCP and get all their care coordinated by the oncologist. So that's something we're going to have to look into as well. I wasn't tracking what you were saying about the medical director.
Yeah, it's not very common, but some primary care physicians might also be a medical director at a skilled nursing facility. And so in the claims, you'll see a number of claims for a particular patient who's a resident at one of these skilled nursing facilities attributed to that doctor who appears as a primary care physician. And that isn't necessarily a bad thing in itself, but what it would mean is that the average cost and average risk of that population would be far higher if you're comparing another group who has primary care physicians who are not medical directors in skilled nursing facilities.
Okay, because
so that's primarily going to be a problem, David, if that physician, if that medical group didn't have any physicians who were medical directors at nursing facilities one year, and then they did the next year. But if that physician is serving patients at a nursing facility both years, because we're measuring trend, it's not as much of a problem.
Okay.
Does that make sense?
Okay, maybe. Maybe. I'm not quite sure I'm convinced.
Michael, in that scenario, wouldn't they be, we're not necessarily looking at the individual physician's performance,
no, it's the medical group.
So the medical group, it'd still flow up to the medical group?
Right.
Okay. Even if there's a SNF, there's a patient being served in a SNF, or I guess does the medical director, does that matter, I guess?
Well,
yeah.
I mean, this is, it's not definitely going to be the case, but this is more likely perhaps to be someone in a Medicare Advantage plan, not in a commercial plan.
I guess where I would care if I'm a medical group who does this, I'll be concerned that in public reporting, my PMPM cost will look very high relative to a group who doesn't do this.
Right.
Now, maybe your point is don't care about that.
Right. We're not going to report that right now.
But at some point you'll have to address that.
All we're reporting, David, initially, for what we're planning right now, is just the change in PMPM spend, but not the actual PMPM spend.
Yeah. But at some point you will.
We haven't talked about it.
Yeah.
But you're right. At that point, if we are going to talk about it, then we have a big risk adjustment issue to talk about.
So my advice is anticipate those issues before you run into the pothole and think about it so that when you do introduce that, you haven't got a problem that you didn't have a good solution to.
And on the last point, we're not doing specialty attribution.
We're not we're focused on primary care physician attribution. But the example David was giving was some people use their specialist as more or less like a PCP.
We've got Hector, Sarah, and then Andrew.
Thank you again. So just wanted to reiterate what David said about these other ancillary costs and tracking those. My question is, how are HSAs and FSAs going to be calculated and out-of-pocket expenses? And then secondly, is there any way that we could track when patients pay for their own care, as Duncan mentioned, chiropractic and others, including buying medications over the counter, buying medications in Mexico, those kinds of things, which are significant. Alternative medicine, for example, a report I saw recently, it's estimated to be about $20 billion industry, mostly paid cash by individuals. So, we'd be missing a huge chunk of expenses and payments if we don't think about long-term how to look at those costs.
Yeah, thanks very much, Hector. On the HSAs, we will not necessarily be keeping track of HSAs. So again, the data that we'll have access to is what the health plan is required to track in terms of copays, deductibles, and cost sharing. You all, at every meeting, folks bring up this very important topic of the fact that people are paying for some services outside of their plans. I think Carolyn raised about long-term care. We've heard about dental. We've heard about behavioral health a lot. And so we're not aware of a good data source for that. So I think it is very important. We're continuing to look at data sources and encourage folks who have specific suggestions. So we know it's an important piece, and we just are not aware of how to capture those costs.
All right, we'll close it up with comments from Sarah and Andrew.
Actually, this is on the topic of behavioral health care out-of-pocket spending, which it sounds like people are pretty familiar. That's a big chunk of how mental health is paid for. And I actually had gotten this email I belong to CalPERS as part of my health insurance, and they, before I got on to CalPERS, they surveyed their members on mental health care access, and it looks like 10,000 responded, and those who did receive mental health care, more than half received care outside their health plan. And this was a survey, it looks like UC Davis Center for Healthcare Policy and Research on the Behavioral Health Access Project helped CalPERS with. And because this is such an important area and so many people have to pay out of pocket for mental health care, I'm thinking this may be possibly a model to collect that data. That's essential.
Thank you. Andrew?
Yeah, I guess, Vishal, maybe a question. How big is the unattributed? So I'm just, in any given year, a good chunk of the population don't have claims, right? Especially if you're dealing with a high deductible PPO. So it affects the denominator of what you're measuring. So I guess it's probably, it's a hard issue for a PPO. I guess I'm just trying to figure out how big is it? Is a 1% issue a 2% issue? So I can make a story in my mind that anybody who, is looking for low cost is probably not on a PPO. And so you probably have higher utilizers on PPOs, but then you have a lot of high deductible PPOs out there. And so you will have a lot of people who don't utilize. So I guess I'm just trying to think through how you would do attribution for those.
So you want me to answer?
Yeah, go ahead.
So it's a lot of people who are going to be unattributed. It's going to be less in California than in other states because the HMO market share is so much higher. But in the PPO population, there'll be a lot of people who will not be attributed, not just because they didn't seek care, but because they sought care at an urgent care center or from a specialist and they had no primary care. So what does that mean? It means that when you're measuring at the provider organization level, all those non-users, they're not going to show up, or non-users or non-primary care users. So they're going to be invisible.
Right. So I guess in the big measurement, they're all there, right?
Right.
But so as you...
They're going to be there at the plan level, at the market level, at the state level.
Right.
But they're not going to be all there at the provider organization.
All right, we're going to pause.
Can I ask a quick follow-up question for that? So if a Medi-Cal managed care plan randomly assigns, but they're never seen at that provider, but they only utilize the emergency room because they've never actually come in. I'm in an FQHC. That happens all the time. I'm curious how that gets worked out.
So what we're talking about right now is assignment counts. So that person would still be assigned to the FQHC even though you could never bring the person in.
I see.
All right, thank you. We'd like to pause for public comment on these two items before we shift to our third THCE item. I invite members of the public to step towards the podium and members joining us virtually to raise their hand. If you're dialing in, press *5.
Here we go. Ben Johnson, California Hospital Association. In danger of being a broken record on this one, but would appreciate continued reconsideration of the intent not to do clinical risk adjustment in the spending target program. Understand concerns related to upcoding and so forth, but in our research found that sex and age, they really only explain about 1% of the variance in spending. And so you'd have a 50-fold increase in the explanatory power of including clinical risk adjustment. And we just don't think that that is an academic concern, but it will have major impacts and implications for equity as providers or other entities are discouraged from seeing many of California's most vulnerable patients. Second thing is just would appreciate ongoing engagement on patient attribution. It's a really critical part of what the office is going to be doing, and false positives and other challenges could really undermine the functioning and credibility of the spending target program. So would just appreciate early engagement with providers. I know you have engaged payers already. Yeah, that's my comments. Thank you.
Thank you. Looking to members virtually, seeing no hands raised, noting that we have roughly 50 attendees virtually, going back to the individual at the podium in the room.
Beth Capel on behalf of Health Access California. We've supported the decision to limit risk adjustment at the state level to age and gender, in part out of an equity concern that those who are low-income communities of color tend to have less access to care and thus tend to not show up with the same sort of clinical factors that those who have ample access to care tend to have, as well as the other concerns presented today about the upcoding that has been pervasive in the states that have relied on it. So it was in the earlier presentations to the board. I think it's an important consideration for the advisory committee to know that that underutilization also threads through. So thank you.
Thank you. Seeing no hands raised at this time, inviting members of the public in the room to step to the podium. Seeing none, seeing no hands raised, that will close public comment on these two agenda items. Moving on to methodology.
So I'll be covering this segment of the agenda for OCA's draft decisions on total healthcare expenditure data collection for the baseline report. Next slide. So the next few slides will highlight OCA's tentative decisions on the measurement methodology for the baseline report, summarized according to the following categories, and I'll be co-presenting this with Assistant Deputy Director CJ Howard. So we're going to be discussing this segment in terms of spending that is being measured, spending data sources, spending analysis, and characterizing and understanding spending. Next slide. So in terms of this first category of spending that is being measured, OCA will measure spending for residents of California, regardless of where they seek care. So this means that we would capture spending for services delivered out of state for a California resident, as long as, the health plan, it's a claim that they paid. And then we would also measure claims payments, which is a category of THCE. We're going to measure consumer out-of-pocket spending obligation. This is the obligation for cost sharing for copays, coinsurance, and deductible for all claims for covered services. It's not the actual paid amount because we don't have a data source for that, or the data source has gaps because of unpaid cost sharing obligations. But this would be kind of per the benefit design of the health plan. This is what the consumer is obligated to pay for that service. And then moving on to the next slide, we'll also be measuring non-claims-based payments. So these are the 6 categories that are going to be under non-claims. As many of you are aware, California has a high degree of capitation and other non-claims-based payments, such as performance incentives. Later in the agenda, you will hear from Assistant Deputy Director Margareta Brandt on how this topic of non-claims payments can be used to measure alternative payment model adoption. So she'll be walking you through more details on that. And then going on to the next slide. So these are the data sources for spending for total healthcare expenditures. We'll be collecting aggregate healthcare spending data across all markets from carriers with 40,000 or more enrolled lives in commercial Medicare or Medi-Cal. I do want to note that for non-MCO or non-managed care organization Medi-Cal spending, we'll be collecting that from the Department of Healthcare Services. We have frequent touch bases with them about the significant share of spending that's happening outside of MCOs. And then for traditional Medicare fee-for-service spending and Part D Medicare Advantage standalone plans, OCA will be collecting that data from CMS or the Centers for Medicare and Medicaid Services. And then for other spending, this is other spending in terms of OCA being as comprehensive as it can be in measuring healthcare spending in the state for where there's a data source. OCA will likely include VA or Veterans Affairs spending, Indian Health Services, California Department of Corrections and Rehabilitation or CDCR spending for state correctional facilities. And then for this last category of insurer admin costs and profits, we're also going to be collecting that either directly from the health plans or from financial statements when they're not available. So the data sources for this include CMS, SIO, or the Center for Consumer Information and Insurance Oversight. DMHC could also be another possibility, or the other regulator, CDI. And then NAIC, or National Association of Insurance Carrier Commissioners, for Medi-Cal MCOs or Medicare Advantage. And then going on to the next slide. So in terms of what is all this data collection going to enable OCA to do? So this is a nice visual. We've showed you a similar version of this, and when we were introducing spending target programs at the last meeting, we've actually built this out to tailor to California's tentative decisions on data collection. So at the highest level, we'll be able to track per capita healthcare spending on a statewide basis. And then because of the sheer size and population of California, there's a great interest in having a regional breakout. So we expect to be able to disaggregate the data by 25 regions, and CJ Howard will cover the specific regions shortly. We will also be able to break out spending by the different public and private markets, including Medicaid, Medicare, and commercial. Will also be able to report spending performance by specific healthcare entities, as shown in boxes 4 and 5. So we'll want to look at specific Medi-Cal plans, specific Medicare Advantage carriers, as well as commercial carriers. And then do want to note in the italicized notes under commercial, we do plan to report spending performance by product type. So this is actually something that we're implementing as a result of a recommendation from the advisory committee about reporting spending performance for HMO capitated products versus EPO, exclusive provider organization, preferred provider organization, PPO products, just because those two products do, they're very different. So that's that covers all of it through 4, and then I do want to just pause on the last column of service category. So those are listed here, and then I'll elaborate on them in the next slide. So if you could advance the next slide. So so for service category, the service categories are listed here. So it includes hospital inpatient, hospital outpatient, professional. For professional, I do want to note that this is this category intersects with OCA's activities to measure primary care and behavioral health spending. So for the baseline report, we're going to capture professional as a very aggregate bucket, but we will need to define what services count for primary care and behavioral health services, including the types of providers and settings in which they're performed. So once that work is done and we've launched some stakeholder processes, such as the investment and payment work group, and then we'll be bringing OCA's recommendations to this work group and then eventually to the board, this category professional is going to be defined further. For example, there may be, professional primary care, professional behavioral health, and so on. I do want to note for service categories, we do expect the data to be more populated when there's a claim for each service. We expect commercial PPO products that pay fee for service to report more complete data that will enable a service category breakout, while HMO or capitated products, the data may be less complete due to the prevalence of non-claims payments. And then lastly, I think that covers my portion of the draft decisions, and then I'll be passing it over to CJ to cover the remainder.
All right, good afternoon. So just to continue off where Vishal left off, so we plan on being able to collect the data such that we can report spending by geography. We are going to use the covered California regions, but for Los Angeles County, LA County only has 2 covered California regions, covering approximately 10 million Californians. So as to allow a little bit more granularity for the large population, we're going to use the service planning areas, which split LA up into 8 service planning areas. And then lastly, on the sort of last bucket of tentative design decisions that we have for our baseline collection, we discussed most of these, if not all of them, at our last advisory committee meeting. With confidence intervals, we do plan to collect the standard deviations related to spending so that we can calculate and conduct confidence intervals around payer and provider performance relative to the spending target. This also allows us to assess sort of variability or volatility within spending at the payer and provider levels. using the standard deviation as a proxy for that variability. We also, as we've discussed today, and to just reiterate, our tentative decision is that we will be collecting the age and sex data to enable for the demographic adjustment when measuring year-over-year spending growth at the payer and provider entity levels. With regard to truncation, that was the concept where we would recode outlier spending above some threshold. We've decided that we will not be collecting the truncated spending amounts or recoding that outlier spending. So we're just going to take the total healthcare expenditures as seen, and so there's no sort of windsoring or smoothing for the outlier spend. We're going to capture, again, total healthcare expenditures, and so that's where we've landed on truncation tentatively. I'm going to go through one more slide before kind of teeing up discussion. So all of these decisions need to be, in order to make them effective, we'll need to promulgate regulations to do so. We've been working with a payer technical work group on a data submission guide that would bring all this data in-house so that we could do the analyses based off of the data that we've described. And then there'll be a regulatory package. And so our plan is to publish the draft regulations in October. So don't worry, we've got plenty of time to get those regulations done by next month. And then, thank you. And then in November, we'll have a public workshop so that we can solicit feedback. And then we'll also bring the results from the public workshop and have a board discussion for hearing. We'll update the board on any substantive changes that we may have made based off of their input in November, as well as the public workshop in November. So that'll happen in December, with the plan that we would submit the draft regulations to the Office of Administrative Law in late January, early February, making the regulations effective in the spring of 2024, so late February, March, give or take. And then that will set us up for our first data collection, and I'll show you in our next agenda item, there's a timeline that'll hopefully also help cement some of this, but our first data collection then would happen in this September of 2024. Are there any questions about the tentative decisions that OCA's landed on for either Deputy Director Pagani or myself?
So I've got Stacy, David, Eliza, Carolyn.
Thank you. It's mostly a question for clarification. So if it's HMO and it's capitated, the health plans will submit just the capitated per member per month, the total dollars. What would they be? So they're not submitting encounters, or are they?
For to measure the spending.
Yes. Yeah. For the non-claims based.
For non-claims. It's if the health plan is making non-claims payments to the provider. So if they're making capitated payments to a group, that's going to count under non-claims.
So it would just be the per member per month value, or total dollars, or what would they be submitting?
The aggregate capitated amount. So no encounters.
So just dollars.
Mm-hmm. Yeah, in general, that's what payers are going to report to OCA is just dollars. So dollars and member months.
Right. So we submit all of our encounters to all of our health plans. It's a requirement in our contracts, and we have the ability to submit those directly to OCA or wherever. So if you think about the narrow networks and the design, so if you're looking year-to-year changes, you could have employer groups shifting around. So CAP is based on the benefit plan structure. Higher copays, you have less cap in your capitated payment. If it's less, more rich benefits, where you have lower copays, you have a higher cap rate. So just a word of caution, I think we need to look at how the impact is if there's changes year to year, which there are with narrow networks and employer shifting maybe to provider or health plan. It could shift, I think, the total dollars paid or per member per month amount.
Stacey, we have to figure out how to do this, but we're measuring the allowed amounts.
Mm-hmm.
So we have to figure out how to calculate the allowed amount that sits on top of the capitation.
Yeah, and that's easier said than done if you're asking the health plans to submit that, I think, down to the provider level.
Yeah, but that's how we need to address that issue of changing benefit plan design.
Yeah. Tall order.
Great. David, Eliza, Carolyn, and Ken.
I have a question about truncation. I understand what you said, that you won't reprice large unusual claims, but the actual payment amount that we would make if we're taking full risk, the amount we would pay would be the amount allowed less our reinsurance that we get paid by a reinsurance provider. So the actual cost would not be the full allowed amount, it would be the amount less reinsurance. Are you going to try to adjust for that? I don't know how material it is in the grand scheme of things, but with a Medicare population, it can be sometimes pretty significant impact.
David, are you talking about stop loss insurance?
Yeah, that's another
Okay.
word for the same thing. Yeah.
Okay.
We're not adjusting for stop loss.
So just to explain what I mean, so we could get $1 million claim, but the actual payment we would make would be $1 million less the reinsurance. And if we have, say, a $300,000 limit, the amount above $300,000 is paid for by the reinsurance company. So the cost to us as a risk-taking entity is $300,000, not $1 million, for that claim.
Right, but for these measurement purposes, it's $1 million. Despite the fact that you had a reinsurer help you manage the risk.
So it really violates the principle of trying to measure what the actual costs are.
Well, there was $1 million of spending. It's just that the reinsurer covered part of it.
Yeah.
Right. But there was $1 million.
But the employer or the member or the health plan didn't pay for the $1 million. They paid for the $300,000. So I think to me it's a flaw in the reasoning to not include the reinsurance adjustments.
So David, if for reinsurance, like I guess, do you report that to the health plans? Because the way this program's working is we are relying on aggregate payer data submission. So we are dealing with a smaller number of submitters compared to the number of medical groups that are out there, hundreds.
Well, I used myself as an example, but health plans also use reinsurance mechanisms as well to offset catastrophic claims expense. So I think, I don't know how many plans would have the ability to report it, but to me, if you want to be as accurate as possible, you'd want to figure out a way to include the impact of reinsurance.
Okay. Yeah, we could take that back. I do want to also note that on the back end, if somebody did exceed the target due to high claims, as part of the progressive enforcement approach, we would want to learn why. So that doesn't necessarily automatically put you on the path to a performance improvement plan. We'd want to know why, and if it is due to a high cost claim that was out of your control and it happened randomly, then that would be a valid explanation for why the entity exceeded the target. And OCA wouldn't pursue any enforcement action, but it's a little bit difficult for us to account for all those circumstances on the front end, kind of due to the data, the way data flows and getting information about every medical group's reinsurance policies.
Yeah, I mean, I don't think you have to necessarily go that approach, but I think from my mind, I'm assuming that when you collect the administrative costs, it would include for a health plan the reinsurance premiums they pay. So to my mind, if you're going to include the reinsurance premiums they pay
at the plan level,
it's doesn't seem right to not include the benefit they get from it in reducing the PMPM healthcare costs.
Okay. When you do negotiations for your cap rates, is the stop loss policy, is that like a consideration during those discussions?
Yes, in terms of what we could accept in capitation, we'd be looking at how much protection we have through a stop loss or reinsurance arrangement.
Okay, thank you.
Eliza, Carolyn, Ken.
My first question was the same as Stacy's, so that's an answer. The second question I had in the list of things that are covered, I saw retail pharmacy, and the question is, have you considered trending separately specialty pharma or medical pharmacy? beyond getting it reported through the hospital inpatient or outpatient data.
So that is an area of interest in terms of analytics on the medical benefit for pharmacy. I think for the first baseline report submission, we are going to focus on retail pharmacy. As you noted, the medical benefit would be captured on the hospital side. I think another source for that analysis later on when OCA does cost driver analysis, because the aggregate summary data is only going to tell us so much. We're going to have to do cost driver analysis using the APCD. So that could potentially be a use case for that. And we are aware of some of the work that the other sibling departments are doing, Cover California and CalPERS, on finding out kind of all the J codes associated with not the specialty drugs, but the physician administered drugs is what I'm trying to say. So that could be some analysis that OCA does to complement the aggregate summary data.
Carolyn.
Wow. Let me just start with wow. This is such a challenging situation all the way around. And I'm looking right now at the comparison of what it's saying here that we're going to be measuring against the breakdown of the regions geographically on how it's being measured. I'm just going to focus on the region that I live in, which is that Northern California area, literally taking up 1/3 of the state in terms of geographic territory, but not nearly that in comparison to actual demographic population. Just in our area alone, I'll give you a quick example. We have one major clinic in Butte County, which is the most highly populated area. That one major clinic and that region has 0 available PCPs, 0. Closest PCP is about an hour and a half away to 2 hours away, coming down into your greater Sacramento region. So that's where we're going now for primary care. When you go to the clinic and you want care, that's basically outpatient emergency service. You are now paying $100 or more out of pocket, presupposing you have coverage through your employment. If you don't, of course, then you're walking into emergency room because you're Medi-Cal servicing, or you're taking advantage of urgent care. There is a ton of spending that we are just missing here by the criteria that I'm looking at. And I'm honestly sitting here, I came here thinking, okay, at least hold that seat, be the voice for what is currently happening in the communities that we service. I'm not saying there's an immediate resolution here. What I am clearly seeing is we are missing a huge, huge data collection element, because none of that is getting covered in what I am seeing here. And I don't know what the solution is. I'm just questioning why we're pushing forward without actively looking for that solution at the same time as we move forward.
Thank you very much, Carolyn. It's so critical to have your voice here in the room. And we are looking at every available data source and acknowledge that there are some challenges. And so keep raising these issues and keep being honest. So, I mean, you know, if the patient goes to urgent care and they have coverage, we will be capturing some of that spending. And we do continue to be concerned about the non-availability of some of the out-of-pocket spending that isn't captured by the plan.
Yeah, it is such a huge element. I think we're all sitting at this table in recognition of the fact that there are literally, I'm going to put it out there has to be millions, if not billions of dollars going out of pocket statewide at this point. That how do we move forward saying we're making things more affordable when that's not factored in?
Thanks. David brought up a good point about the stop loss, and from a claims adjudication standpoint, my question is whether stop loss reimbursements traditionally are applied to the individual claimant. I know in our self-funded program, we didn't go back into the claim records and negate or mitigate what was paid. That money was applied to the trust assets, but at the end of the year, our consultant factored the gross reimbursements against our total spend. So I don't know if any of the health plans go back and individually adjust the claims for which a reimbursement was made, but the health plans would probably only be getting it on insured groups, because self-funded, if they're paying their claims third party or through a TPA, that just is an income to the plan or the trust. So that would be a tough one. And question I have on under services for specialty meds, is there going to be total capture of limited distribution drugs that may not be issued through a group's PBM, and also when specialty drugs are issued directly through a physician? Is that included under retail pharmacy?
It's not under retail, but it's physician administered drugs would be under the medical benefit. So depending on the setting it's delivered in, it could be an outpatient or hospital outpatient or professional spending. So it's not going to be, it's going to be captured in the totals, but it's not going to be broken out as a specific line item. But we do have an interest in understanding it as a cost driver. So that's where the HPD could be a potential source for that when OCA pivots to doing more cost driver analyses.
Okay, thank you.
In terms of improving encounter data, I know this has been a conversation where all of us who've been involved on the HPD side have been talking through how to improve the encounter data for several years now, and was wondering what the progress looks like there and what the next steps for getting us to better encounter data look like.
We do coordinate with the Office of Information Services, so I could take that question back. But in terms of encounters, that's not something OCA is specifically going to be focused on measuring. That's more for the HPD.
But even on the spending side, you're seeing it's not because with subdelegation, is all of that just getting rolled up to the delegated rather than flowing through to the subdelegated?
So in terms of data submission, the encounters would tell you what the utilization is in terms of what services are performed, but they may or may not have cost information. But OCA will measure the non-claims payments, which, capitation being the largest part. So we'll get the spending information. We just won't get the encounters. OCA directly, but then in terms of the HPD, I know they do have a plan to collect encounter data. So for any analyses we do on healthcare spending in California at a more granular level, where we need the claims data and the encounter data, then we would be able to do other cost driver analyses using that.
Okay, I'd encourage us to over time get to a place where we're at better completeness there, because I have a feeling that's masking a fair amount.
Thank you.
All right, just doing a time check now. We're at about 2:35. Hoping to wrap this item up and move to the next item soon. Do you have more, CJ?
No.
All right, thank you. We'll move to public comment. Members of the public in the room, please step to the podium. Members attending virtually, please raise your hand. Seeing no hands raised, seeing no one stepping to the podium. Give it a moment. Now it's time for a 10-minute break. So we will reconvene at 2:45. All right, welcome back. And we're now moving on to introduction to methodology considerations for the statewide spending target. We'll have Assistant Deputy Director CJ Howard.
All right, hello again. You might have thought that you were done with me for the day, but not quite yet. I'm gonna keep the jokes coming because, well, if I could first figure out how to advance the slide, that would help. Here we go. But the moment that we've all been waiting for, I feel like we've talked a lot about collecting spending, but we were here for the healthcare spending targets program, and so here we finally get to talk about targets and setting of targets and what the work that the board and OCA is going to be undertaking in the coming months and ultimately years. But we're going to start small, so we'll crawl, walk, run. But so first, just again to level set, so what is a spending target? A spending target is an annual rate of growth, so generally expressed as a percentage. So what we're measuring is the change in spending from one year to the next, with some sort of idea of a target that we don't want the growth to exceed. So because I used to be a high school teacher, I'm prone to childish analogies, so if you'll bear with me. A perfect example is if my ninth grader scored 80 or 100% on a test, and there was extra credit the next year, and he scored 103%, then he grew by 3%. So that's kind of what we're looking at here. If you spent $100 on your shoes last year and you spent $110 the following year, you had a 10% rate of growth in your shoes. That's what we're measuring. It's that change from one year to the next. So states have adopted these targets to slow the growth rate because we want to say, look, I don't want to spend $110 on my shoes, or I don't want to spend another 8 or 9 or 10 or 12 or 15% on healthcare. We want to have some target that we can all agree to, or at least rally around, to say that's an acceptable, sustainable level of growth that we should be shooting towards. So I think we all know that healthcare spending has long exceeded the economic growth. Per capita spending on healthcare has grown faster than inflation, wages, and other consumer measures, making healthcare increasingly unaffordable. And so that's the purpose for why we're pursuing a target. There we go. Let's just get all of those up there. All right, so California spending target methodology. So today we're going to review the statutory requirements and considerations, including the board and OCA responsibilities and our timeline. We're going to review other states' methodologies. We're going to introduce some economic indicators and population indicators that we might want to think about tying the target to. And then we'll review other factors identified in statute for possible spending target adjustments. I'll also note that we're having this discussion today, and we're also having the same discussion with the board tomorrow. So a lot of what we hear today, we'll do our best to integrate into the board's discussion tomorrow. Next slide. So the board shall establish a statewide healthcare spending. So the statutory requirements for setting this, and I'm going to go through two different elements of this. So there are both the requirements that are placed upon the board, and then there are also requirements that are placed upon OCA. Many of them will echo and or rhyme with one another, but it is called out separately in statute. And so I'm just going to review those considerations separately for clarity. So the board, for statute, the board shall establish a statewide healthcare spending target for the 2025 calendar year and for each calendar year thereafter. The statewide target must meet the following criteria. So it must promote a predictable and sustainable rate of change in per capita total healthcare expenditures. It must be based on a target percentage with considerations of economic indicators and or population-based measures. Be developed with a methodology that is transparent and available to the public. Talk a little bit more about the methodology in a second. Be set for each calendar year with a consideration for multi-year targets or setting the target for multiple years into the future. The setting of the target also has to be developed, applied, and enforced. Be updated periodically and consider relevant adjustment factors. Promote improved affordability while maintaining quality and equitable access to care, including consideration of persons with disabilities and chronic illness. Promote the stability of the healthcare workforce and be adjusted for provider entities to account for growth in organized labor costs. So that's what the board will need to do when they're establishing the target. And in setting that target, it'll be based upon a methodology, which we go to the next slide. Oh, sorry, got ahead of myself before that. So that's what the board will do. The board shall also establish specific targets by healthcare sector, including fully integrated delivery systems, geographic regions, and individual healthcare entities as appropriate. The sector targets must be established on or before July 1, 2028. So we're going to be focusing on the statewide target in our initial discussions, and we'll be focusing most of our time here on the statewide target, noting already, I think today there's obviously interest in these other sector-specific targets, just calling out that it's not prescribed for in statute for a couple years. So we are going to try to, in that spirit of crawl, walk, run, we're going to talk more about the statewide target first and establishing that methodology. So now if we could go to the next slide. So OCA, so we talked about the board's responsibilities and how they'll ultimately be the setter of the statewide target, but they'll set it on a methodology that OCA develops, but that the board approves. So the board will also have authority for approving the methodology, and the methodology must be available and transparent to the public. The methodology must be based on a review of historical trends and projections or forecasts of economic and population-based measures, based on a review of historical cost trends with different treatment for COVID-19 years. Consider potential factors to adjust future cost adjustments, including but not limited to healthcare employment cost index, labor costs, consumer price index, and other factors. Consider several criteria related to Medi-Cal, including but not limited to the non-federal share of spending, maintaining federal requirements to ensure full financial participation of healthcare-related taxes or fees, provide the non-federal share. That's a mouthful, but thanks for bearing with me. And the last three requirements is that we need to allow the board to adjust cost targets downward when warranted for healthcare entities that deliver high-cost care that is not commensurate with improvements in quality. Allow the board to adjust cost targets upward when warranted for healthcare entities that deliver low-cost, high-quality care, and require the board to adjust cost targets as appropriate for a provider or fully integrated delivery system to account for actual or projected non-supervisory employee organized labor costs. Additional criteria apply when setting sector-specific targets. These will be reviewed in a future meeting. Before I open it up to questions, I think it's also helpful that we get to the next slide, which kind of puts a lot of this into context, and especially as we've been discussing about how this all gets phased in. I'm going to try to see if this works without blinding anybody. Actually, it's not, because I'm not going to walk away from the podium. So we're just going to, if we orient ourselves to the top line where it says we're going to set spending targets. So the board will have to set at least the first year. Here it shows that potentially they've set more than 1 year worth of a spending target, but they'll set a target for each calendar year. The first one will be set in 2024 for spending that occurs in 2025. And what that is it's actually the change that occurred in spending between calendar year 2024 and calendar year 2025. So that's what we're measuring, the growth or the change in spend. So each time that the provider or that the payer groups submit data to us, and each time we collect data, we're going to be collecting 2 years worth of data. We're going to measure the difference. There's generally going to be like a 6-month run out period. So we're going to be collecting it. So the spend that occurred in 2025, we're going to wait for the claims to be adjudicated. We'll collect that data in 2026. The report then wouldn't get released until 2027. So the first time that we will be reporting against a statewide spending target actually won't happen until 2027, when we release our first statutorily required annual report, and then each subsequent year. And so if we keep going down from there, which is sort of in the middle of that timeline, you'll see for 2025 and 2026, we'll collect that data in 2027, report on it in 2028. That's the first year that enforcement would be applied. So that's where we would start the progressive enforcement process, starting with technical assistance, potentially performance improvement plans, public testimony, performance improvement plans, and ultimately financial penalties. And that's sort of the cadence that we would get on. Whether or not to be determined how and when, or whether or not the 2026 target will be set early, or when that'll be done, that'll be a discussion that we have with the board soon, starting tomorrow. Backing up just a bit though to the top. So our first baseline report though, we will not be performing against a spending target. Our first baseline report will be published in 2025. We're going to collect that data. That's what we were discussing, all of the data elements that we were going to collect that we just went over in the last hour. That's what we'll be collecting in 2024, and we'll be collecting 2022 and 2023 spend, comparing the difference and just reporting what each payer or provider's growth was based off of 2022 and 2023. But it won't be relative to a target, obviously, because we have not yet to establish one for calendar year 2023, nor will we. So I hope this helps put some of the work into the broader lens or the broader picture of how this is going to be phased in. I will note that while statute is quiet on whether or not there is a 2023-2024 report, for purposes of getting reps under our belt before the first annual report that's required, our intention is to collect data in 2025 and do a second report. And we're calling that the 2023-2024 report before our first required annual report, which would be against a spending target. Questions about the charge before I hand it over to Michael Baylett to discuss a background about what other states have done, and how some of the measures that we could look at and get your input on the measures or population indicators.
Yeah, go ahead, David.
I have a question back to page 76, if you don't mind. Sorry, my numbers are different from your numbers. It's yeah, no, that's what it is, 76. Can you go down one?
It's due to when we added in slides for our breaks that would.
Right, next, I think it might be 77 or 78 then. No, it's 78, I think. No? Keep going. It's the healthcare spending target methodology development continued. Oh, that's it. Yeah. Yeah. I had a question about this. Require the board to adjust cost targets to account for actual projected employee organized labor costs. I just want to understand the thinking behind that, because I can imagine if you have a hospital system, say, that has a unionized workforce, I think you're saying there you would include the projected labor costs of that unionized workforce in the target setting?
It's not a projected cost. So David, there's a process under the statute where once the targets are set, if there's a subsequent union agreement that's reached, a party can come and submit data and ask for their target to be adjusted.
Okay. So I thank you for that clarification. The question I want to ask is, if I run a hospital in the same area and I don't have a unionized workforce, and most likely whatever that agreement's going to be is going to establish a new hourly expectation, and I probably, as that hospital, going to keep my employees, I may have to match whatever's being negotiated. So is there a process for the non-union to make a similar petition?
There isn't a process to have the board change the target subsequently, but there would be a process in terms of communicating with OCA that that was one of the reasons that the entity didn't meet the spending growth target.
Okay. So my input would be it seems unfair to a facility that happens to have a non-unionized workforce to not have the same options that a hospital with a unionized workforce has. That doesn't seem equitable to me.
Actually, David runs physician groups. I have a hospital system, and we have in the same market 2 hospitals that have had a long-standing and very good relationship with California Nurses Association for 21 years, and 2 hospitals that have no union. They pull from the same labor market. So when the Long Beach hospitals renew a contract, the other hospitals shadow price. And it happens not even within the same system. When Kaiser increases, the market increases, the non-union market. So I think we need to consider that. And it might be useful to require those entities to demonstrate what value that has brought, those additional costs. It can be, I think, very easily measurable, increases in retention, reductions in turnover, increases in employee engagement, employee satisfaction. All those are very measurable things that could go with those market adjustments.
You know, we appreciate that. And of course, there's a lot that goes into the development of legislation. So this is the statute that we ended up with, and certainly agree with all of the points. And as you all, I think we've talked about, and actually Margareta Branch is going to come talk about some of our performance measure components that include a workforce stability measure. And so I think all the benefits that you did talk about would be captured there, hopefully.
Yeah, I was going to also kind of try to ask about the workforce stability question and trying to address these issues about, you know, whether or not the spending target would be increased based on labor costs. And I think really the important part here with increasing the spending limit based on collective bargaining agreements and agreements reached with the unions is that the workforce is unionized and that there is a guarantee that benefit, whether it's wages or compensation or additional working condition protections for workers, is actually provided, and that there's an enforceable way to ensure that those workers have it. Whereas if you're just expanding the spending target with the promise of you know, that labor costs are expensive in an area, there's no real guarantee that those workers are going to get that benefit. So I think that that's really one of the concerns there. I did have a question though, based on something I was thinking about in the previous discussion, is for the statewide spending target, if there's a way that we can figure out. I think one of the things that we were talking about was really a concern about how do we make sure that the spending targets aren't, you know, deflated or impacted because we're not calculating how much out-of-pocket spending there is. I think that is there a way that we can make sure that the spending targets accurately reflect that, and that we're not inappropriately setting the spending target because costs have been shifted onto patients or shifted onto workers or shifted onto payers. So I think, or you know, plans or and whatnot. So if there's a way that we can address it, that would also be something that I think we should consider.
Parker and then Joanne.
Okay, we're on. I realize that this topic could obviously get into a much larger, like, philosophical topic, but I want to bring it, my comment back to kind of my perspective I'm bringing here, which is one of primary care, in particular underserved primary care. So when you talk about target and what are we going to spend money on, one could always raise the question of, is spending more on healthcare a good or bad thing? And that's probably a bigger discussion, but when we look at it as a good or try and equate it to shoes, that misses the value, the potential real value of healthcare. A couple of things we know is the number one most effective dollar spent in healthcare is for primary care. And we know that the number one least effective dollar spent in the American healthcare system is the administration. And so to the extent that this target can start to tease that out or look at that, I would put a vote towards that would be valuable. And so my question is there anything coming, or at what point will this start to address that notion of, we know very well by data that there's good places to spend and very inefficient places to spend, and when will that come in?
Yeah, thanks very much, Parker. We are getting to that topic later today and definitely in the years to come. So one of the portions of the OCA statute does have setting a threshold for investment in primary care as well as behavioral health. So absolutely what we're looking for is high value care. So we will be measuring admin costs and profits, and we will be setting a goal toward as trying to achieve the goal that you acknowledge, which is that research is clear that investment in primary care both increases outcomes, improves outcomes, and also decreases costs.
I had a timing question on the side of allowing the board to adjust targets up and down based on value and cost. I know that the statewide spending target is the first multiple years, but do you have a sense of roughly when those criteria will be starting to get developed? And can you talk a little bit about what data you'll be trying to pull from there?
Yeah, that's a set of activities that we're actively working on. There's no statutory deadline for this quality adjustment, but it is something that we're actively working on. In terms of some of the data that's out there are the hospital quality measures that are being reported, and HCI will, in out years be collecting the equity measures as well. And then DMHC health plan quality and equity measures as well. And then, NCQA, National Committee for Quality Assurance, also collects various health plan HEDIS measures as well. So we're going to be looking at kind of those existing measures that are out there. And then we're going to have to present an approach through the stakeholder process and the board for this quality adjustment.
Okay, that gets to the quality side. Do you have a sense of, as you're thinking about the cost side, as to, I'm just trying to think about even what year to start thinking about this in.
Yeah, we don't have an answer for that right now, but it is something we're working on.
Okay.
All right, I'm going to hand it over to Michael so we can start talking about the actual methodology and some of the considerations for how we might go about setting the spending target.
Thanks, CJ. So I'm going to share with you a little bit about targets and target setting in other states, just to give a little context. So there are 8 states that have established healthcare spending targets to date. They're listed here. They have all set their targets informed by some measure or measures of state economic growth or indicators of resident financial well-being. Okay, they have not all done it the same way, as you will see shortly. They've all had a governing body, sometimes also complemented by a stakeholder body like you, that have considered, when they look at the candidate measures, so what is the measure, how's it calculated, and how is it relevant to what we as a body are trying to do, and what's the message if we adopt this indicator or indicators as the basis for setting the value or values. All of the states, when they set their target value, looked at historical spending growth within the state across 3 distinct markets, Medicare, Medicaid, and the commercial market. They all set multi-year targets. So the statute gives flexibility for the board to set a 1-year target or multi-year targets. All the other states did multi-years. as short as 4, as long as 10. I would say most are 5. Okay, there's nothing magic about 5. I will say, though, that one of the reasons for a multi-year target is, as CJ just explained, year 1, you don't report out until 2 years later. So you can't really evaluate what your experience is with the spending target and with the target values until a few years have passed, because there's a 2-year lag before you're making the performance public. So that's why states might not pick a 1 or a 2 year, because you don't know what performance has been like at the time that you're setting your next values. The values that were set by states for 2018 to 2022 range between 2.9 and 3.8%. Actually, I think one state, Nevada, went below 2.9. They set their values roughly 2% below historical spending growth within the state. And when I say historical spending growth, that's for the whole state, because historically, commercial market growth has been way higher than Medicaid and Medicare spending growth nationally. So this is 2 percentage points about below the state level. Now, some of you might think, what happened when inflation hit? Okay, because all these values were set before inflation spiked in the fourth quarter of 2021. The states that had set their values that ran through 2021, 2022, 2023, they all left their values in place, despite the spike in inflation. And they did so from a pro-consumer perspective, because they said inflation is just making things worse for consumers, and so we need to protect affordability for consumers. So we're not adjusting. There's one state, however, that had its initial targets end in 2022. So they had to set a new value for 2023. And this is a state that's operating under a compact agreement among stakeholders. So they have to negotiate it out. It's not being set by a board or by the governor's office or some other entity. So they wound up, as you'll see on a couple slides, they wound up negotiating so that there was a temporary spike upwards for 2023 and 2024, and then coming back down. Okay, that's the only state, though, where there was an inflation adjustment. So here are the values I'm going to show to you for all of the states. This is small print, but there are a few points that I want to point out to you. One is, while the very first state, Massachusetts, picked one indicator and they said that's the basis for our target, the tendency across states has been to use multiple indicators and to use indicators that include both state economic growth and some measure of resident economic well-being. And it's usually some type of a weighted average. That's been a little bit of the trend. Now, it's only 8 states, so I can't say there's that much of a trend, but there's been a movement away from just using state economic growth. That's clear. 2, you'll see in the target value column that there are a lot of values. So there's been a trend in the states to set an initial value that's a little above where they want to be, and then to go down. I guess it's a transitional strategy based on a belief that it's going to take time for payer and provider organizations, principally provider organizations to be fair, to make transitions. And so some of the states, actually most of the states, have this stepped program. I'm not going to explain the individual values under target methodology. We're going to talk about values a little bit later. But I will, what's the one point I wanted to say? But I will say that all the states, except for one, that use more than one indicator have developed a formula to get to their target. There's only one state that sort of took a bunch of considerations together and then negotiated out a value, but there's not actually a mathematic formula that they adopted, but all the others did. So those are 4 of the states. Here are the other 4 states. Rhode Island's the one state that had to set new values for 2023 because their initial values expired at the end of 2022. And so this is the state where you can see for their first 4 years, it was 3.2%. They went up for a couple of years and then coming back down. They changed their methodology a little bit. And so their landing spot's going to be 3.3%. But you can see in general, the states are all in this high 2s to low 3s. And on the far right column, you can see what their historical spending growth was. Generally 4, 5, 6 range. Okay, so the statute for setting a spending target value or values for California requires a consideration of economic indicators and population-based measures. So none of those other states I showed you had anything called a population-based measure, but your statute requires it. So, so we will discuss both economic indicators and what we think are appropriate population-based measures. I'm going to share with you a set of indicators for discussion. They are for discussion. There are other ideas that you might generate. The board might generate some ideas tomorrow. The public might have some ideas. That's fine. This is a conversation starter. The measures I'm going to share are measures for which there are historical data available and there are forecasted data available. Okay, we wanted to make sure that we only considered measures where both were available. The State Department of Finance does economic projections, and so we looked at what are the measures for which they do projections. If they don't do projections, we didn't consider them. Okay, so that was one of the considerations. The statute says that the economic indicators should reflect the broad economy, labor markets, and consumer cost trends. So that's pretty general language. So for each of the indicators that I'm going to present, I'm going to explain to you what's it measuring and what might be the measure if the target was pegged to the indicator. Okay, so this is the group of 6 indicators. I'm going to walk through them sequentially. I'm going to start with a couple of measures that are focused on the state economy, then a couple of consumer economic measures, actually 3, and then finally a population-based indicator. For each one, I'm going to say what's it measuring, what would the message be, and at the next meeting, I'm going to share with you what's the annual rate of growth been and what are forecasts for it. But today, we're just talking about the measures in concept, and the purpose is to get your feedback on whether you think the measure in concept lends itself well to being used to inform the spending target. And again, you can say that you like more than one. You can also identify another measure that indicator that's not here that you think should be considered. Again, we have a constraint in terms of available data, at least if we use forecasts. But I just want to note that constraint. So it's possible to use both historical data and to use forecasts. Other states have tended to use forecasted data, but at least one state used historical data. So let me talk about the difference between the two. So historical data means we're going to look back 5, 10, 20 years. That's open for discussion. When we look at historical data, it's volatile because our economy goes up and down. We have boom and bust cycles all the time. Even when we don't have a pandemic, that's true. So you get a very bumpy line for any economic indicator if you look at historical data. And so the values you come up with are going to be influenced by the length of the time period that you're looking back. If you look at a very short time period, you're at high risk of being influenced by whatever happened recently. A longer time period, you're going to smooth out the economic growth and periods of difficulty. It's easy to access this information. And it's easy to make calculations to average what was performance over a certain time period. If there are bumps, there are techniques for smoothing them a little bit. Okay, if there's some strange event like a pandemic that shuts down the economy, there are ways to account for them if you want to. Forecasted data are very different. Forecasted data are maybe a little bumpy for the first couple of years, and then for the long term, they're straight lines. So a lot of states have liked forecasted data because they're simple. There's one long-term figure if you go out, say, 5 years plus. I will note that forecasted figures are informed by historical data. They don't come out of a crystal ball. So there's a relationship between the two. They're not totally divorced. As I said, the Department of Finance regularly forecasts economic indicators for other purposes, but we can potentially apply them here. Methods of forecasting are variable. There are both public forecasts, as through the Department of Finance. There are also private economic forecasting firms that states often license data from that do forecasting as well, and they use different techniques. Questions about anything on the last couple of slides? No? I know it's getting late in the day, but stay with me. This is really good stuff. Yeah.
I did have a question on the table with the states and the small numbers.
Yeah.
There's a row that says add-on factors. Can you explain what those are?
Yeah. So for example, Connecticut said we're going to use an 80-20 mix of median household income and potential gross state product, which gets us at 2.9%. But we don't want to start at 2.9%. We want to start a little bit higher to help phase in our spending target. So they came up with add-on factors. There's nothing scientific about them at all, but they just said we want to start a little bit higher and step down to get to 2.9%. Okay. Okay, so 6 indicators. Indicator number 1, state gross state product. This is the state version of GDP, and it looks at the value of goods and services produced in the state. So this is the state economy. State product tells us how fast the economy either has been growing, or if we use a forecasted value, how fast it's projected to grow. The message here, if we tie the spending target to GSP, is healthcare spending shouldn't grow any faster than the state economy. Okay, I'm not saying if that's right or it's wrong, but it's a concept that's certainly carried some weight in some other states, because a lot of states have picked economic growth in some fashion. A related measure, and I'm listing this one because it's used in a lot of states, and it was used first in Massachusetts. Okay, so I should tell you that Massachusetts developed its spending target with significant influence by an economist. Okay, economists know this measure, gross state product, potential gross state product. The lay population does not know this measure. That's how Massachusetts got to it, and a lot of the initial states said, we like what Massachusetts is doing, so we're going to borrow from Massachusetts. So they adopted PGSP too. That doesn't mean this isn't a good idea, but this is not as well understood a measure as the other ones I'm sharing with you. So this is a forecast of state economic growth, but it's not calculated the same way that GSP is. Okay, but it is a forecast of state economic growth, and it gives a nice flat value that's stable for the long term if it's used. The inputs to calculate it are publicly available, so you don't have to go to a private commercial forecasting firm to do this. And if this was developed, adopted, we would be saying, again, spending should not grow faster than the state economy. A little bit on how these two measures differ. So GSP, it's labor income, capital income, and business taxes added together. That's the state economy. PGSP is quite different. It's looking at growth in labor force productivity plus inflation plus the size of the labor force minus population growth. So you can see they're dramatically different in terms of how they're calculated. Okay, so these first couple of measures or indicators are state economic growth. Let's look at 3 that are focused more on the economic well-being of Californians. So this first one is looking at median family income. We pick median here because we know that income gets pulled upwards by people at the high end of the scale. And it does not really reflect the experience of Californians. So that's why we pick the median value. Median family income is all of the income of a household among members who are related in some fashion. Okay, that's different than household income, which is just all the people living together. So this is people who in some fashion are a family unit, and it reflects their pooled resources. So this measure gives us some sense of the purchasing power of Californians and how is it growing over time. And the use of this indicator would say healthcare spending should not grow any faster than the income of the median Californian family. Right. All right, number 4, average wage of Californians. So this is a narrower view than family income because family income includes income from other sources, capital gains, dividends, rent, interest. That's not included here. This is just pure wages. Okay, and obviously people of lesser economic means tend to have less access to those other sources of income. So this is a measure really of take-home pay in more direct terms, and this says that if we were to select this indicator, that healthcare spending should not grow faster than people's paychecks. That's what we're measuring here, paychecks. Yeah.
You turn the microphone.
By average.
Microphone. There. Sorry.
Sorry. Why average, not median for the?
Because the Department of Finance does not forecast median wages. They only do average wages. So as I said, we're trying to go with values for which there are forecast values available. If in time the board decides we don't care about forecasts, we want to use historical data, then median would be a possibility for us. But because we don't know yet whether we're going to go with historical or forecast, we only included measures for which a forecast was available. Yeah, good question. Any other questions on the indicators that I've shared so far?
Is it possible to go through which of these can be broken out geographically as opposed to which are only available statewide?
I don't know the answer to that right now,
okay.
So no. It's a good question for another day, though, Joe.
Stacy.
Thank you. When we say wage, what is it for a senior retiree? What are we talking about? Their Social Security checks, or what do we?
That's a good question. I don't know if Social Security is included in this.
Yeah,
that's something for us to look into.
Yeah, I'm just struggling with, we have increasing seniors, but they're not exactly connected to these measures, right?
Yeah. I have a feeling it's not included. I think it's included in the prior measure for household income, but I don't think it's included here. I think this is just for working Californians. Okay, so that's a consideration. Okay, last measure is inflation. there are many inflation measures. This particular one, the Consumer Price Index, is the one that we probably all know the best. It's not the one that the federal government uses. It uses PCE. But CPI is the one that we all know the best. CPI is a market basket of goods purchased by consumers. The most commonly used version of it is the CPIU, which captures the experience of 94% of Americans. It says urban, but it's not really. And this gives us a sense of how all prices are rising over time. And if we were to select this, we would say healthcare spending shouldn't grow faster than the rise in consumer prices. Now, sometimes people will say, all right, but healthcare costs are a reflection of both utilization and price, so this isn't a good indicator to use for healthcare. But from a consumer perspective, the premium you pay is a price. The payment you make for a service, at a provider's office, that's a price. So for consumers, actually, healthcare does appear as a price. For those of us who know how healthcare spending develops, we know that there are prices and utilization. But the consumer experience it's a price. This is another way through a consumer-centric lens of thinking about affordability.
Got a question from David.
Just a question. I know sometimes you hear about CPI, core CPI or core inflation, excluding things that are volatile like gasoline prices. Has there been any thought about something like that here?
Yes. So I should have said that, but yeah, what we're talking about here is CPI less food and energy, because food and energy are the volatile components of CPI. Okay, and last, median age. So this is our one population indicator. I am shortly going to ask you if you have other suggestions for population indicators. As I noted earlier, and as you saw, other states don't use this. We're suggesting median age because we know that aging does contribute to healthcare utilization and to spending growth. If we were to include median age as an indicator or indicators, then we would want to assess what the impact of aging is, again, over the course of a year. It's a similar conversation on age sex adjustment many hours ago. But we'd want to think about what's the impact of aging on spending. This could be used in conjunction with another measure. So you could pick one of the other indicators and say, and also we want to adjust for any aging that occurs within our population, because that's expected to grow spending. So that might be just a little tiny bump on top of whatever would be the other indicator or indicators that we're adopting. Vishal?
Just as with other topics, this is we wanted to pause to ask if you have any questions or suggestions regarding the use of one or more of the economic indicators or the population-based measure that we reviewed. And then if there's others that we didn't include, if you could suggest those and then also explain why OCA should consider those.
Okay, any comments? Yeah, David?
I do have one suggestion, which is I think we all know that drug costs are a very significant part of total healthcare expenditure, and arguably they're outside the control of the state of California. So having some kind of adjustment for that piece might be worth considering, because those drug costs are way above state GDP or CPI, non-core CPI. They're far above that, so that might be something worth considering.
Great, thank you. Sarah?
I'm not an economist, but I'm wondering if an indicator that should be used should be the one that most closely approximates someone's discretionary income or increase in their income or decrease, because that kind of is going to be what really matters. The other ones like gross state product may not really relate to the average individual's ability to pay for health care.
Thank you, Suzanne. And then Anthony.
Yeah, I mean, I'd want to agree with that sentiment that the state gross product and even the potential one is not as related to an individual or a family's experience. Those are, I mean, California is an amazing state, and lots of iPhones sold, lots of movies streamed, but that's not necessarily how people experience the economy and expenses in their own right. I think we very much strongly prefer those that are grounded in a consumer's experience, whether it's wage growth, a family income, or something in that realm. Our goal is not to come up with like a calculation of how the health system spends money and add them all up and then see if it gets to a sum. It is actually to encourage innovation and efficiencies in the system so that our health system is actually affordable and sustainably affordable for families. And so I think the more we could focus in on that, and I do think that to the extent that we do have things built in both the front end and then in the back end with regard to in the enforcement place to make adjustments if the Sovaldi gets introduced that sort of spikes cost for a certain amount, that like the spirit of this is that it's not that sort of very especially in the formulation of this was not that it's not this very formulaic rate review process where you're just doing this addition process, both to encourage innovation to bring down the cost, but also that you also have some flexibility, and I think that's built in the front and back end. And so, but I think the message that Michael was talking about is really important, which is the message that we're trying to have a healthcare system that is sustainable for families and how they experience it, and that's the thing that we want to get at the end of the day.
Thank you, Suzanne.
And
then Hector.
Yeah, I'll give the same sentiment that having affordability be defined by the individuals that are paying for the healthcare is really important. So whether that's the average median income or it was average wage or the median household income, I think both of those reflect the fact that even as I've always represented employer payer or purchasers of the system, and even if we are paying for 90 to 95% of the cost on a member responsibility, it always of course trickles down. So each individual person in the healthcare system is paying for that cost, whether or not it's actually a card being swiped or an invoice being paid. So I do think that actually measuring affordability based on what consumers can spend will hit them, whether or not it's what they're at the doctor or in premiums. And I do think that also ties back to this idea that because we're considering this an emergency measure, we're getting closer to like crisis, and obviously the housing crisis is something that the government is having to step into even further. So I think we could see this in a crisis situation, we see this as preventive as possible to try to help mitigate some of those further issues that, again, California is a really great state. Supply and demand, it becomes a little harder in an economic measure when you're looking at something like housing or healthcare. And I do see healthcare as, I think a lot of people here, not to say that everyone would agree, but do feel that healthcare is very important to provide to all Californians. And so affordability being tied to what people can pay for it would be really valuable.
Thank you. So we'll do Hector, Janice, Joan, and Stacy.
Did you model the targets to cryptocurrency by any chance?
That wasn't an idea I came up with, Hector, but it's a creative one.
Yeah. We're getting punchy, so that's what we need. No, I just want to echo what Sarah and Sean said about looking at the consumer. you know, there's a segment in my patient population that is really getting slammed. You know, the cost shift that subsidizes what, you know, providers consider inferior payment for Medicare and Medi-Cal is commercial insurance. And the employers are figuring out, along with the health plans, to cost shift that shift to the worker and their families. And maybe an indicator of that would be how much premium contribution is changing out of the worker's paycheck, and what those deductibles and co-pays look like, because they're just trying to weather the storm. You know, there was a report from Milliman that the average out-of-pocket expenditures in California for families is $10,000 a year, and they only have $400 in the bank, which means they're maximizing their credit cards, and that's hard to track. But we can definitely track the cost shift from commercial insurance and see how that impacts our ability to have targets.
Thank you, Janice.
Yeah, I agree with Anthony and Suzanne. At the end of the day, this is about affordability and access for Californians to access healthcare. And so I think in terms of simplicity, looking at both the average wage of Californians and then also capturing those folks who might not be captured under the wage indicator with household income, I think will be a good kind of starting off point to figure out how we create that spending cost growth target.
Okay, thank you, Joan.
Along those same lines, I would encourage us to look to medians, not means. And I would include both of the growth product metrics as essentially means, because they are looking at the sum. They are including those very high-end outliers, whether those dollars are accruing to businesses or to individuals, whereas something like median wage, median income is centering on the experience of actual Californians. But once we're starting to include money that is accruing at the very high end, that's just a completely different economy and is not getting spent on healthcare in the percentages that the money at the median is getting spent. And so anything that, so particularly gross state product, where that experience of business is coming into play so heavily, just does not strike me as reflective of what we're trying to do to increase affordability. So I'd point us toward those medians rather than those means.
Thank you, Stacy.
So if you could refresh my memory in terms of the targets, will there be separate targets for commercial members versus Medicaid versus Medicare?
So there will be the first target will be a statewide target for 2025, which is an unenforceable year. 2026 and forward is still statewide, and 2028 is the first year that the board could set, or on or before 2028 could do sector targets.
So what I'm having this debate in my head about is we're having seniors, you know, every year we're having, or every day we're having, you know, thousands of people flip into Medicare fee-for-service or Medicare Advantage. The cost is greater, the revenue is greater, right? So if you take our health plan revenue, all of a sudden you're going to see this trend that's going to grow significantly more than if they just stayed in, if you looked at commercial by itself. So just just the aging of our Californians is going to show a higher trend. And so I don't know how we adjust for that, except until you get down to that, I call it product level, commercial members, senior members, and Medicaid members. So the trend's going to be much higher as you go through that. And then, an example of cost underneath the hood is we follow the health plan criteria under capitation. So we look at each health plan, Aetna is a separate, United, Blue Shield, to see what their coverage criteria is. So the GLP-1s, the specialty pharmacy for obesity, we have people clamoring for this $1,000 a month injectable, right? And so how does that get factored in? I guess, is that a corrective action plan discussion? You know, and it may be different by health plan because of the coverage criteria that it could be different. So it's a huge escalating cost that's frightening.
We appreciate all of that input and your point earlier about needing to really dig in and see how seniors' income is even included in some of these measures. There won't be any corrective action plans, or as we call them, performance improvement plans, until 2028 at the soonest for the 2026 target. But we could certainly look at individual circumstances like the obesity drugs. And I just wanted to make a quick process point, which is that, you know, the last time you all met was the day after the board meeting. Today, you all may know that you're meeting before the board meeting. So CJ Howard has the unenviable task of capturing, you know, your input. And so the board will actually be getting basically the same presentation tomorrow from Vishal and Michael and CJ. And so we'll be capturing your input as the board considers what economic indicators to include.
Thank you.
Appreciate it.
I actually had a question. Age is a population-based measure. What are some other examples of population-based measures?
We were going to ask all of you for ideas on that. But to be honest, aside from age, there were not a lot of obvious options that occurred to us. So if you have ideas of what you think would be good population-based measures, we would love them.
What about things like I don't know if this is a population-based measure, but rate of like homelessness or industry work in like service industry versus professional or those sort of things.
We certainly can consider a range of measures, but we would have to be able to establish what's the relationship between that and total state healthcare spending, especially because the initial target is state spending. So that's the only qualifier we have. Age we probably could do, but I'm not sure about some of those others.
Carolyn. I just want to make sure, did I hear you say earlier that other states are not using age as a factor? And if not, why? Did I hear that?
Yeah, so other states are only using economic indicators.
Is there a reason why?
I think because the goal of the target is to slow spending, and they thought, well, what should be the basis for slowing spending? And so they thought about economic indicators.
Okay.
They certainly all could have included other bases for setting their measures, but they didn't. That's all I can say.
Stephanie and then Hector. You speak into the microphone, Stephanie.
Would agricultural workers that come here temporarily during the harvest seasons, I see large groups of people coming in that are doing a lot of the work in the state. Aren't they a population? Is that captured?
So it's captured if they are covered by commercial Medicare or Medi-Cal. Okay, but otherwise, if there's healthcare spending associated with them and it's not flowing through one of those, then we don't have any way of capturing that spending. Okay, and I know this has been a theme for both of our meetings, is people are frustrated that there are payments that are happening that we can't capture. It's largely a result of us not having a data source for it, especially people paying out of pocket. There's just no way for us to know about that spending.
COVID relief funds that were used for people without insurance weren't, right? I'm lost.
So the COVID relief payments, which I think have now all passed, some of those passed through in terms of Medicare rates. A lot of them were direct payments that went to hospitals that were off the ledger, so to speak. And the only way that we know about them is at the most gross level. So the federal government might say, $8 gazillion went to California. And you might be able to find information on how much went to each hospital, but that's it. And it was a very time-limited phenomenon. And frankly, the time periods that we are now looking at for the target are going to be well past the date that those payments were made.
Thank you. Hector, Suzanne, and then Sarah.
Income inequality continues to be fought less and is getting worse and worse. A third, maybe 36% of our population is now on Medi-Cal. So looking at a population-based measure would be those living in poverty, and I would say up to 200% of the federal poverty level as an indicator for our targets, because those are the populations that when their payer is considered inferior, it induces cost shifting and cost somewhere else. And so maybe something to consider would be to look at people living in poverty and up to 200% of the federal poverty level.
Suzanne.
I was only going to add, maybe speaking from experience with a lot of ag workers, that they are captured in a lot of either the Medi-Cal or private worker space because they're residents and they're on a lot of plans because the seasonal workforce is pretty long. So,
Sarah and then Andrew.
My question was a follow-up to really Stephanie's point, and then Suzanne's is, and also thinking about FQHCs that are serving the uninsured. While a claim isn't generated, that information is captured. So I'm just curious, because it sounded like if someone was uninsured, that wouldn't be captured.
Yeah, so this is a frequent topic in states, is spending for people who are uninsured. So 2 points here. First, we're measuring spending and not provider costs. So if an FQHC experiences costs by serving someone who's not insured, there's no spending for those services unless they're either paying out of pocket or there's some other state fund or federal fund that's helping to cover it. That being said, there are some people who are self-pay, who are uninsured, who show up and who might pay some small amount. And certainly,
Yes, I mean, slight, yeah,
or not small. Go ahead.
Yeah,
Continue.
sorry.
Right, or not
We're
small.
just commenting, sorry.
Yeah. Yeah. So there are some providers, hospitals especially, that tend to capture information on those payments, but there are other providers that don't capture it at all. So states that have considered how do we capture self-pay by people who are uninsured have had to think, what's our data source for that information? So no state has opted to do this, okay? But one option is to say, well, we're going to go to all the hospitals and ask them to tell us. And if the FQHCs have that information, we'll have them tell us. And that's what we'll include in our spending. And for every other type of provider for whom we don't have an easy way to get data, we'll just say we're not including it. Okay, so you could get partial information, but you would have to go to providers and have them report that information to the state. So you got to create a whole new data collection infrastructure if you don't have it already. And states might have it for hospitals. I don't know about California. So that is an option. It's a partial option.
All right, I'm going to do a time check. It's about 3:55, noting that we do have a couple of people lined up with comments, but we do need to move on. So I have Andrew, Samana, and Carmen.
Yeah, I just wanted to say the median income or median wage actually has intuitive appeal to me, just because we're talking about consumer affordability. Now, the thing that I'm struggling with, I guess, in my mind is, all right, let's say we come up with a measure. How do we do the add-ons, right, that are required by statute, like the demo change? You know, how do you add on the demo risk adjustment, and then how do you add on the adjustment for labor? So it's the, you know, it's almost like this is a base, right? And you add on some of the adjustments, and
So when you say that the demo risk adjustment, you're talking about the population based?
Right. So, you know.
Right. So that's something that the board has to consider. It doesn't have to adopt.
Okay. But then it has to adopt the labor adjustment, right?
It does have to adopt the labor adjustment.
Right. So it's the, I guess I'm thinking through, right, some of these measures probably already have pieces of that in there. So, it'll be hard to tease them out. But
So we talked about this a little earlier. My take on the labor one is that a provider organization that, let's say, exceeded the spending target could come to OCA and say, well, we signed a new organized labor agreement and we gave out, a big wage increase, and that directly corresponded to an increase in our rates with our payers, and that's what caused us to go over the spending target.
okay, so you're thinking about it as a back-end adjustment, right? So I'm thinking about it, let's say prospectively.
Yeah.
Right. So if you are a large hospital system and you're negotiating with labor, right? So the first position is, oh, well, the OCA targets are this, right? So I don't know. I mean, maybe that's the intent of it, but.
Well, so the way that it's written in the statute is that that an entity has to come and provide some documentation of the wage increase. So de facto, it's done retrospectively, not prospectively. But you're right, there's a dynamic that's going to play out in negotiations, right, where, but I think we're going on a tangent.
We might.
Yeah, I'd add that we're still working on the process and the timeline for this. In terms of the data and information we're going to have to collect to make the adjustment. So right now it's conceptual, but in terms of implementation, we're going to have to spell that out more clearly. So more to come on that topic.
All right, we do need to move on, but Samana and Carmen lined up. Is the mic on?
Median concept, and I think Parker and Hector would probably agree that this is a great state in which the uninsured at this point have mostly figured out to go to FQHCs where they are captured. In my practice now, I think the only uninsured I see, and I'm sorry to say this, and I think it's tiny, are people who are attached to an FQHC or another clinic with Medi-Cal, but tell me they don't have insurance because they want to see me. And I think it's a tiny group, but I don't think it's significant,
All right, Carmen, and then we'll move on.
Yeah, just really quickly, I was trying to wrap my head around what data points that we can use for the out-of-pocket spend provision or portion that we're struggling to figure out. Has any state or have you looked into how medical debt rates could be used or actual provision of charity care or something along those lines to figure out, in terms of like what information that's already out there on uninsured, underinsured folks?
Other states just haven't done that. They stuck with, we're going to use whatever information is available from payers, and we recognize that leaves some holes, but for our big purpose, we're okay with that. Okay, I'm not saying that's right or wrong, but that's what they've done.
Yeah, go ahead, Michael. Are you at the end of your?
I'm at the end, but Vishal's not at the end.
Thank you.
Thank you, Michael. So I'll be covering our last slide. This is in the statute about potential factors to adjust future targets. So we're aware that, once you set a target, there's going to be new policies or, changes in prices, changes in provider payer mixes, other mandates. So this allows the board to revisit the setting of the target in future years to look at these other types of factors. It's including but not limited to list. So some of them are listed here. Some of them we did go over, like the Consumer Price Index, which was one of the economic indicators we reviewed. Let's say the board sets a multi-year target, and then once that term for that multi-year target is nearing to completion and we need to look towards future years, then we could look at these other data sources to know if we really got it right, or do we need to make some tweaks, or do we need to go in a different direction. This does allow the board to weigh additional factors to adjust future targets. And there's not so much to, in terms of asking questions or getting direct input now on this topic, but when OCA is going to be adjusting targets in the future, this will be something we're going to revisit for input and recommendations on.
Great. I believe that concludes this agenda item. We'll move to public comment. Individuals in the room, please step towards the podium. Those attending virtually, please raise your hand. Going to the individual in the room.
Beth Capel, Health Access. In addition to the comments of Anthony Wright, our Executive Director, I'd like to add that on Friday, the UC Berkeley Labor Center published a publication on economic indicators that I think the board would find very helpful. And among the things that it included is those that could be compiled by Covered California Region, which includes both median wages, median household income, and gross domestic product. So I do think we have some options. Apparently, potential gross state product is not something that California currently develops. And so it's not an established indicator in the state of California. Whoever that economist was in Massachusetts who came up with this, our preference obviously is for established indicators and for those that reflect, as this advisory committee discussion has reflected, the ability of consumers to afford. We would say both care and coverage. Thank you.
Thank you. Looking virtually, seeing no hands raised, going back to the podium.
Hi, Ben Johnson from California Hospital Association again. Just echo CJ's enthusiasm for getting into the meat of the spending target discussion here today. And would just want to emphasize what we believe to be the multi-pronged goals that the office is set to achieve, with we think the key provision in statute being promote improved affordability while maintaining quality and equitable care, including considerations of persons with disability and chronic illness. And so we just ask that the office and the advisory committee and board really remain focused on this underlying goal, which we think to be related to really improving the value proposition of California's healthcare delivery system and its cost effectiveness. And we do have questions around whether or not the office can achieve these multi-pronged goals by picking a spending target exclusively based on an economic indicator that is not necessarily related to the drivers of healthcare spending. So we do encourage the office to consider more surgical, more nuanced approaches, identifying areas where spending can be reduced by improving the value, improving the cost effectiveness, and so on. And in addition, we just asked the office to consider really at the outset the factors that it showed on that last slide that it provided. First, population aging already been discussed, and appreciate that. But we'll just share that projections show that the population over 65 is projected to double in the state over the coming decades, and the targets should reflect this. The after effects of the pandemic are also significant, and healthcare entities are trying now to recover from those. And then the major impacts of new state mandates, seismic compliance, a potential new minimum wage on the healthcare industry, and so forth, that these spending targets really need to adjust. So thank you for the opportunity to comment.
Looking to other individuals in the room, virtually, noting that we have 39 attendees, seeing no hands raised, seeing no one step into the podium.
Just one note that seismic standards are not a new requirement. So Margareta is going to come do a last presentation. It's going to be fabulous. Stand up for a minute. Get your energy going. Move your body. Stand up like Stacy if you want to. This is important stuff. All right, we're ready for you, Margareta.
Thank you, Elizabeth.
Okay. Keep standing if you want.
Yeah, you're welcome to keep standing. Good afternoon, everyone. Margareta Brandt. I'm the Assistant Deputy Director for Health System Performance here at the office. Today, I'll be sharing an overview of our work related to 4 of the 5 focus areas for health system performance: alternative payment models, primary care and behavioral health investment, and workforce stability. I presented most of this content at the June board meeting, so it's probably familiar to some of you, but there are a few updates sprinkled in. So there are 5 focus areas for promoting health system performance, for promoting high-value health system performance: primary care and behavioral health investment, alternative payment model adoption, quality and equity measurement, and workforce stability. And across these 5 areas, really our goal is to reorient the healthcare system towards greater value, with the vision of creating a sustainable healthcare system that provides high quality, affordable, equitable care to all Californians. And so today, again, we'll focus on 4 of the 5 areas, and that's really tied to our statutory deadlines for these areas. And we will come back to you in probably several months and or next year with focus on quality and equity measurement. So for each of these areas, I'll walk through the statutory requirements, review the evidence for each of the areas, and then describe similar efforts in other states and share our proposed approach and timelines. Sorry. Can we go to the next slide? Thank you. So starting with primary care and behavioral health investments, the statutory requirements here focus on 3 components. So one, of course, is measuring primary care and behavioral health spend as a portion of total healthcare spending. 2 is setting benchmarks for primary care and behavioral health spend as a percent of total spending. And 3 is to promote improved outcomes for primary care and behavioral health. And getting into primary care evidence today. So about 2 years ago, I'm sure many of you may have read the highlights of this report. The National Academies of Science, Engineering, and Medicine, or NASEM, released a report documenting actions needed to strengthen primary care in the United States. And recommendations are really aligned with our work. Specifically, it calls for policies that pay for primary care teams to care for people, not doctors to deliver services, ensure high quality primary care is available to every individual, train primary care teams where people live and work, design IT that serves the patient and the family and the care team, and ensure high quality primary care is available throughout the United States. So the NASEM report notes that implementing high quality primary care begins by committing to pay more and pay differently for primary care services. And as noted here on the slide, primary care investment in the US lags other high income nations. Our spending is about 1/2 to 1/3 of those other nations, and our outcomes are worse. And so inspired by this report, a few groups got together to create the first national primary care scorecard, which evaluates primary care spending using nationally publicly available data. And as you'll note on this side, that California was a bit higher than the national average, with about 6.3% of total spending across all payers in 2020, compared to 4.6% nationally. But again, still lagged behind those international comparisons quite significantly. And so over the past few years, sorry, I'm not sure if this is working. Thank you. A growing number of states have begun efforts to strengthen primary care through measuring and reporting on investment. More than a dozen states now have measured and reported primary care spending at least once. And 5 states, Rhode Island, Oklahoma, Oregon, Colorado, and Delaware, now require a defined level of primary care investment for at least one payer type. And as we'll discuss more in a minute, measuring spending on behavioral health services delivered in primary care has increasingly become an important component of this work in many states. So now turning to behavioral health. Many states have increasingly focused on behavioral health investment in the last few years, in part due to the impact of the pandemic. And as noted here, nationally and in California, nearly a third of adults are reporting symptoms of anxiety or depression. And this data is from earlier this year. And unfortunately, we know these individuals are not receiving appropriate treatment. The California Healthcare Foundation analysis from a few years ago found that nearly 2/3 of adults with mental illness in California did not receive treatment. So these data points just highlight the need for investment in behavioral health. And the good news is that we know that healthcare delivery models that integrate primary care and behavioral health have been shown to be effective in improving access and improving health outcomes and deliver a return on investment for reducing downstream costs. So as I mentioned earlier, several states are measuring behavioral health investment. There are 9 states that do so. 3 of those states measure behavioral health investment across the full continuum of services. And this work is just emerging within the last few years. And so California can really build on what these states are learning. So best practices are emerging around the diagnoses, services, providers that are included in definitions, but there's no standard kind of nationwide definition. So each state is, defining behavioral health and/or primary care differently to get to their benchmarks and measure investment. So next, we will turn to alternative payment models. So here for alternative payment models, the statute specifies 4 components. One is to promote the transition from fee-for-service-based payments to alternative payment models, measure movement towards alternative payment models, set a statewide goal for adoption of APMs, and that goal could be a percent of members, providers, or payments based on alternative payment models. And 4 is to adopt contracting standards for healthcare entities that encourage multi-payer alignment and promote quality, equity, and efficiency in these models. And so there are other states that monitor alternative payment models, and they use that data in a variety of ways, and we'll talk about that in a bit. Getting to the focus on alternative payment models, we know alternative payment models or value-based payments can incentivize delivering the right care to the right people in the right setting. And to do this, payers and providers consider the level of financial accountability each entity should hold and appropriate incentives for meaningful progress on quality, equity, and efficiency. And APMs include many public and private payment models, and as many of you are probably familiar, these are generally classified using the Healthcare Learning and Action Network framework. And this HCP-LAN, also known as HCP-LAN, established a framework for with categories that define or just categorize the level of risk taken on by each provider. So that's often a way that alternative payment model adoption is tracked. And so while this framework is used in many other states, there are also a couple of other ways that we could track alternative payment model adoption and/or non-claims-based spending, as that's alternative payment model adoption is part of non-claim spending. So we'll talk about categorizing non-claim spending in a bit. So OCA is really charged with promoting the adoption of alternative payment models due to the recognition that the traditional fee-for-service system is not flexible enough to accommodate innovation in how care delivers, and that fee-for-service generally incentivizes providers to do more and not necessarily perform better. And across the nation and in California, a little bit less so in California, but movement towards alternative payment adoption has been quite slow. fee-for-service payments made up about 40% of payments from 2017 through 2021 nationally, according to HCP land surveys. And in California, about 36% of members were cared for under a fee-for-service arrangements in 2021 in the commercial market, for a point of comparison. So what's occurring in other states for alternative payment models? In the past few years, the number of states that are collecting alternative payment model data has doubled, and their interests really vary, and their data collection methods also vary. So some states use it for understanding the non-claims component of total cost of care. Some focus on primary care and behavioral health investment. And similar to California, some states also track the movement from fee-for-service payments to alternative payment models. So these experiences in other states really highlight the difficulty of understanding how non-claims payments are distributed within provider organizations, and that's an area we're continuing to work on and get input on. So, and before we dive into non-claims payments, wanted to talk a little bit about how we recognize that alternative payment models, primary care, and behavioral health investment are related and interconnected. So we're very much coordinating across these work streams. And if we could go to our next slide, we'll talk about our approach. So we have contracted with Friedman Healthcare to support these 3 work streams. So for each work stream, OCA and the Friedman Healthcare team will do, brainstorming, research, summarizing evidence, looking at data and modeling data. We're really looking to build on the foundation of collaboration and alignment in California through purchaser contract requirements, California studies on primary care spend. Our state purchasers, Medi-Cal, Cover California, CalPERS, and others have really paved the way for these areas. And over time, we'll get to developing recommendations with input from stakeholders, including all of you, and then work towards finalizing or seeking board approval of the recommendations. And one way that we are seeking input is through our investment and payment work group. So we launched a work group in June to seek stakeholder input on these 3 work streams and have been meeting monthly since then. And the box on the right lists all the different perspectives we've included in the work group. And the purpose of the work group is really to focus on stakeholder engagement and key program development decisions about primary care definitions, data collection efforts, and then also to provide input and feedback as we develop our recommendations for benchmarks and standards, and to really dig in and discuss those relationships between alternative payment models, primary care, and behavioral health. On the next slide, this is just a few examples of what we've been discussing in the work group. For each work stream, we're discussing definitions, measurement, and reporting. And then in addition, for the alternative payment model work stream, we're discussing contracting standards and the statewide goal for adoption. And then for primary care and behavioral health investment, are discussing that benchmark. So we're currently really focused on the alternative payment model work stream, and we'll be turning to primary care pretty soon. So now I have a little detour on measuring non-claim spending across HCI. So one of the issues we've been discussing in our investment and payment work group and across HCI is how to measure non-claim spending as part of our effort to monitor alternative payment model adoption. So across HCI, there are 4 related efforts. I'm sure many of you are quite familiar with some of these. There's, of course, the total healthcare spending target. So how do we account for non-claims-based payments in the development of the total healthcare spending and tracking total healthcare spending? There's the primary care and behavioral health spending benchmark. So how are we tracking non-claims payments that are tied to primary care and behavioral health? There's also, of course, the alternative payment model adoption effort in terms of better understanding and tracking the payments that are made to providers based on alternative payment model arrangement. and how many members or providers are within those arrangements. And last, there's the healthcare payments database, which will collect more granular information on non-claim spending to support additional analysis. So we looked at different mechanisms and frameworks to measure non-claim spending or to categorize and track non-claim spendings. And in the next few slides, we'll walk through some of those frameworks and then a proposal that we have developed in coordination with our team. So first is the Milbank Memorial Fund, which our dear Michael Baylett and his team helped develop. So this framework was initially aimed to measure non-claims primary care spend and has evolved over the years to support states in tracking total healthcare spending, including non-claims. So it really focuses on identifying and communicating the purpose of the spending. So this is really nice to track spending for the purposes of a benchmark and get a sense of how dollars are spent. And the second is, of course, the Healthcare Payments Learning and Action Network, or HCP LAN framework that I mentioned earlier. And the purpose of HCP LAN is to track and promote alternative payment model adoption. And its framework is designed to categorize payments according to the level of risk taken on by the provider. And use cases for this framework include how do we define value-based care for the purposes of contracting, and how do we measure towards goals or other standards that have been set. So taking these two frameworks and other inputs, OCA worked with Freeman Healthcare and with input from Baylett to essentially crosswalk the Milbank and the HCP LAN frameworks together. And we also updated some of the definitions and categories based on input from the Integrated Healthcare Association's Atlas. And then we revised to show kind of more risk progression and the purpose of payments in a single framework, which gets us to this, at least as a snapshot of the framework, and the next two slides go into more details. So using all these inputs, we developed what we're calling an expanded framework that is a single framework that can capture data in multiple ways and support multiple use cases for defining payment purpose and measuring provider risk. So the core feature of this framework is to essentially crosswalk the Milbank categories with the HCP LAN categories, and we really intend to collect data to capture non-claims-based payments and the portion of total spend by level of provider risk. So this framework has 6 categories, and again, the details are on the next 2 slides. It was a lot to fit on one slide. So those 6 categories are population health and infrastructure payments, performance payments, payments with shared savings and recoupments, capitation and full risk payments, our other bucket of other non-claim spending, and then pharmacy rebates. So this slide lists categories A through C and their associated subcategories. And again, really the purpose of this expanded framework is to allow for a single framework to support multiple use cases, especially defining the payment purpose and measuring provider risk. So for example, category A, population health and infrastructure payments, subcategory A4, practice transformation payments, is crosswalked to the HCP LAN category 2A. So that's just an example of how we can do both using this framework. And then categories D, E, and F and their associated subcategories, at least for D, are on this slide. And in developing this framework, we were especially interested in making sure we captured all the different types of capitation payments that occur in California. So there are 6 subcategories here for capitation and full risk payments. So these categories and subcategories in the expanded framework are more specific than categories in the HCP LAN framework, but still allow us to roll up to those HCP LAN categories too many acronyms. And we think this framework is helpful to categorize non-claim spending to support, our several HCI use cases, especially for data collection for monitoring alternative payment model adoption. And this is still a draft, so we welcome feedback and suggestions for this framework. So now that we've taken a little detour through non-claim spending, I'll come back to our timeline for alternative payment model adoption, primary care, and behavioral health work streams. So this timeline is intended to get us to our statutory deadlines for seeking board approval and adoption. So in summer 2024, we'll seek board approval of the APM contracting standards, primary care spending benchmark, and APM goal. And then in spring 2025, seek approval of the behavioral health spending benchmark. And along the way, anticipate several discussions with this committee and the board, and along with monthly discussions in our investment and payment work group. And this all leads up to developing regulations, collecting data, and reporting in our first annual report in June 2027. So next, I will shift to workforce stability. And I know we're getting close on time, so I'll walk through these slides fairly quickly. So the statutory requirements for workforce stability specify that OCA will monitor the effects of spending growth targets on the healthcare workforce stability, monitor workforce stability with the goal that workforce shortages do not undermine healthcare affordability, access, quality, equity, and culturally and linguistically competent care, promote affordability while recognizing the need to maintain and increase the supply of the trained healthcare workforce, and develop standards to advance the stability of the healthcare workforce in consultation with the board. The statute also specifies that OCA may require a healthcare entity to implement a performance improvement plan to improve spending performance, and the board approves the standards to advance the stability of the healthcare workforce that may apply in the performance improvement plans. So we'll be focusing mostly on the approach and timeline for our general standards, not the standards used in a performance improvement plan, since due to statutory requirements, we need to develop those general standards on or before July 2024. So I'm sure I don't need to tell this group why we are focusing on workforce stability, but as you all know, we currently face significant healthcare workforce shortages, including a an imbalanced geographic distribution of healthcare workers, and the healthcare workforce challenges contribute to a lack of access to needed services. And as the Health Affairs Council on Healthcare Spending and Value noted, efforts to slow spending may have unintended negative consequences if healthcare entities reduce labor through staffing reductions. And we know that a stable, well-prepared, and adequately supplied workforce is essential to a sustainable healthcare system and provides high-quality, equitable care to all. And to date, no other state that has implemented a spending growth target is also looking at workforce stability standards. So unfortunately, I don't have a map to share with you, but we're really interested in working with those states to understand the impact of their spending targets on workforce stability and if they've seen anything as they implement their targets. So getting to our planned approach to develop the workforce stability standards, here OCA has contracted with the Institute for Health Policy Studies and Health Force Center at the University of California, San Francisco to support this work. And this slide provides a high-level approach of this work stream. So we'll start with a literature review, we'll do a data set and metric review to identify, relevant variables and really operationalize the workforce stability standards by identifying accessible metrics that can be monitored over time. We'll conduct several key informant interviews with state and national experts. We'll conduct stakeholder interviews with healthcare entities, healthcare workers, organized labor, consumer advocates, and then After we've conducted this initial work, we'll bring what we've learned and proposed workforce stability standards to the advisory committee, to the board, and release draft standards for public comment, all leading to final workforce stability standards with an iterative process leading up to that. And this last slide provides, I think this is truly the last slide, provides a preliminary timeline for the workforce stability workstream. So throughout 2023, we'll focus on that research, interviews, and developing draft standards. By spring 2024, we'll present draft standards to the advisory committee for your feedback. And by summer 2024, we aim to finalize the standards in consultation with the board. And we anticipate, at least 2 discussions with the advisory committee and the board leading up to summer 2024. And then, of course, following board consultation, we'll get into data analysis to implement the standards starting in fall 2024. And with that, I'm happy to answer any questions. And I also have team members on the line from Friedman Healthcare and UCSF if there are any super specific questions.
Yeah, go ahead.
Thank you for the presentation. And I just wonder how many of you came in here recognizing that 6% of our spend is primary care. And I know that when I first discovered that single number, I have been questioning far and wide, like literally every person I meet, from 10-year-old kid to seasoned healthcare, person. And it is so amazing how wrong people are. And so just to kind of step back and say, this is the single most exciting, heartening thing that's happened in my career, to feel like I've been mulling away in one corner, just seeing patient after patient. And now there is actually a concern that this incredibly under-resourced corner of healthcare has a hope. And the hope translates into, I can go talk to a new physician. And the statistic that 0.5% of new physicians are joining small independent practices might turn around if this happens quickly enough, right? So this is like incredibly practical, urgent, applicable support. And I hope all of you will think of it that way, that if we are given the resources to do the job, then the patient by patient, I can give you endless examples of unreimbursed care, like continuing to talk to every pregnant woman about the importance of COVID vaccine because it's not happening in our local OB community. So it's like a last ditch effort to get them protected, get their newborns protected, and throw out all sorts of things like that. But to make it practical, I'm on that IHI, PBGH committee as well, working on advanced payments for primary care. And again, to be able to say that it's not about each payer doling out some money and we have to prove that we've reached one more HEDIS measure here, as long as you all see that that should not be the intent. And you can, any one of you, come into my practice and see that an additional, reimbursement that allows me to just do my job will provide for every one of those quality measures. But if you overdo the we have to see value, then if that value is 6 HEDIS measures and nothing more, then this will just become more and more complex. So please be really aware of the need to keep the administration to a minimum and just right this ship so that we can keep going. Thank you.
Thank you, Hector, and then Sarah.
Well, one of the best parts of this committee is I got to meet Dr. Reddy. So I appreciate the opportunity. Thanks for your presentation, Margaret. So I think we have a really interesting opportunity to prospectively investigate the principles that you talked about, from APM to primary care, behavioral health, et cetera. And that's with the current Medi-Cal spend, starting with the EPT, the Equity and Practice Transformation Fund, which is not a lot of money. $700 million over 5 years sounds like a lot, but it's not, given the number of solo and small practices that need technical assistance to transform their practice from volume to value, and to pay for teams taking care of patients in primary care rather than paying physicians, right? So EPT is a critical investment. Secondly, is the MCO tax that will actually increase payments for primary care in year one and in the second year and moving forward, primary care and specialty, including outpatient procedures performed for Medi-Cal patients. That's historic. And I'm hopeful that it will improve access to new providers willing to take Medi-Cal, but it definitely will help those that are already currently serving Medi-Cal, especially those in private for-profit practice. One of the great triumphs of affirmative action is that Black, Latino, Asian, and Southeast Asian physicians are serving underserved communities, and they're doing what they said they would do if they were given a chance to become a physician, is to work in an underserved area. This MCO tax is going to help those practices to begin to make this transformation, including that primary care spend and pay for behavioral health, as well as strengthening our GME and workforce program. So, this time I think it'll go not under HCI, but the Physicians for a Healthy California. But, we're all allies in this work. And then the other part is the CalAIM program, which again is Medi-Cal oriented, but there are patients in commercial and seniors, as well as covered California, who need CalAIM type services. So here's an experiment for us to begin addressing those social drivers of health under this one program. We can't lose this opportunity. We're actually spending more money, which, would be contrary to what we're thinking, OCA's responsibility is, but it's making that primary care spend right so that we can actually prove what it can do for the long-term reduction of unnecessary costs and improving the quality of care and bringing equity to the fold. I think is really, really important. So wanted to make that comment because you were at the end of the day and you had to rush through your presentation. And to me, this is as important as the earlier discussions we had on CMIR and total healthcare spend. I think this is something worth spending more time. I'm glad you have a work group looking at this, but I think it'd be really important for members of this committee and the OCA board to work much more closely with those advisors you're going to have, because this can be transformative to everything else that we're talking about there. So thank you.
Great. Yeah, thank you so much for flagging those areas. And we are doing lots of coordination with the other state departments with Medi-Cal. So we'll definitely look into these areas. And I will be back to the committee in November to at least share our draft alternative payment model standards. And so we'll be back in November. But welcome any feedback you all have. You're welcome to email me or anyone on the team.
Thank you, Sarah.
Yeah, so in terms of standards for measuring workforce stability, in particular for behavioral health, I'm wondering if you'll be taking into account things like turnover, both within an agency, so people switching between or from one role to another, not as an advancement, but at least at some workplaces, I've seen a lot of switching roles because you burn out in one, you go to another, you burn out in that one, you go to another, and then also turnover, like leaving the agency, but also the amount of therapists, mental health therapists who provide psychotherapy that don't take insurance, just take out-of-pocket cash pay versus the ones that are providing healthcare in our healthcare system like Medi-Cal, Medicaid, commercial. Because it's my understanding, and I might be wrong about this, but there's more therapists providing care outside of our system. And that could be different if maybe the working conditions and pay were different. But yeah, I'm just wondering how, maybe it's too much to go into, but how workforce stability and behavioral health is being looked at.
Sure. So I don't have many details to share with you yet, but these are all really helpful questions as we get started. And I think kind of part of the challenge, again, with much of what we've discussed today, is if there's data to support monitoring standards like that over time. But it's definitely something we can look into.
Janice?
Thank you. Just a question and another a comment, but how is UCSF choosing who they are planning to interview for the workforce stability work stream?
We are working together. The OCA team and UCSF are working together to, develop a list of stakeholders to interview, and it's very much, based on, who we think has relevant expertise to share, but also who will be impacted by the standards. So, experts and also healthcare workers, organized labor, consumer advocates. So we're really trying to do a wide range of interviews.
Okay. Thank you for that. I also hope that as folks are starting to interview the workforce, that it's not just the trained professionals, the nurses, the physicians, which I think are incredibly important, but the other folks who help run the hospitals. That would be an important focus from our perspective, but also I've been thinking a lot about the correction space and how healthcare is served to their patients, and in terms of workforce stability, what we're seeing is a huge problem with the contracting out of that workforce, especially in behavioral health. So wanted to just put I guess, plug in for capturing that when we talk about workforce stability.
And is it generally in terms of like contracting for healthcare workforce rather than hired workforce?
Exactly.
Okay. Exactly. Sure, that's something we can look into.
Stacy and then Carmen.
Thank you. You covered a lot of material. I can't even get to stability. I'm still on the primary care and behavioral health under capitated model. So is the work group addressing how you would look at a capitated model to identify what's in primary care? And are they also looking at the support services such as case managers, social workers, things of that nature that we have that support our primary care, on-site diabetes educators, the whole thing?
Yes, we'll definitely be looking into how to, account for those if we can. And that's part of, what we're looking for also in the non-claims-based framework that I shared. That expanded framework is how can we capture some of that spending.
Good, that's very important. Thank you.
Carmen.
Thanks for your presentation. I know it's a lot, and I'm look forward to our future discussions when it's not at the end of the day. I want to echo what Janice was saying, and I think on the contracting issue with healthcare workforce, I think a lot of it, maybe a terse way of saying it is the quality of the jobs that are out there, and particularly the impact that contracting out the healthcare workforce could have, both in terms of whether or not they're unionized, whether or not they're being used to lower costs in spite of a collective bargaining agreement. Those types of things, I think those are really important in terms of ensuring that our workers have high quality jobs where they're protected and they have particular rights. And I think, when, the employment structure when you're a contracted worker has an impact of, the rights of those employees. And I think that it's a really important question to make sure that that is addressed in the workforce stability regs. And then I just wanted to quickly comment on the APM reg development and the definition. I know that that's going to be coming up first, and I think I really just want to emphasize that we should be looking at a definition that is broader than just risk-based types of payments, trying to look at different types of payment models that don't create financial incentives to either deny or to diagnose folks. So I think those are really important things to have, and make sure that we're looking outside of the framework of, financial incentives in APMs. It comes to mind. There's been talk about increased additional time pay for time spent with patients, which would be an alternative payment model that wouldn't be a risk-based payment model. I really think that we should use that framework of APMs to broaden our sense of like what are the payments that could be out there for providers.
Thank you.
Great, thank you. We'll do Sarah and then Parker.
I'm personally very excited to talk about APM at 4:45. It really gets at a lot of the solves and the challenges that we have. I just wanted to make a comment, kind of to Stacy's comment, but also that when we're looking at alternative touches, trying to capture those that are not claim-based, that are integral to our integrated behavioral health and primary care systems, speaking from an FQHC perspective, I think what's challenging is when we're looking back, those are often positions that we haven't been able to hire for because of the limitations that we have on billing and provider types. And so it's really challenging to only look back and say, well, how do we go and capture some of those touches now to look at as part of APM? Because when you blow up the system and look at like what kind of care we could provide in behavioral health and what kind of providers we could be using, peer advocates and case managers and community health workers, not just licensed therapists. I'm saying this as a licensed therapist as well, that it takes all of us doing this work. So I would just love to look at how that gets captured. And I think from coming feedback from health plans, or I would say health centers, that feedback could be given. I haven't seen that developed yet with the APM models.
Thanks for flagging that.
Great, thank you. Parker and then Sarah.
Parker Duncan Diaz, and again, want to share my excitement for the primary care focus as a FQHC, family doc, primary care based, and acknowledge that as soon as we start to think about that, of course, there's bigger context that determines a lot of our limits. I'm sure you've probably considered, what keeps a lot of the fee-for-service stuck is the Medicare RUC or RVC committee that sets the prices. It's 22 physicians chartered by the AMA that sets the prices for our reimbursement schedule for all of medical care. And that is largely dominated by the subspecialists and has undervalued primary care since the inception of that committee. So that's a big system thing to tackle. One way to tackle that, of course, is to kind of move away from fee-for-service. But those kind of structural things are there. I just want to pay attention to them and honor that they're there. There's a lot of work that's been done at the California Academy of Family Physicians and at the the American Academy of Family Medicine that is combating that or providing better research to that. And I'd be happy to send you stuff offline too to
Sure.
connect with that.
Welcome anything. And yes, thank you for flagging. That's definitely something we've thought about, but lots more to do.
Lots more to do. Thank you.
Great, thank you. So we'll move to Sarah and then Ken, and noting that we'd like to wrap up soon and we do still want to have public comment.
I'm going to try to see if I can explain this because I may not have the best understanding, but there was some talk about like risk adjustment or using diagnoses to determine payments or reimbursement. Is that
generally some alternative payment models do incorporate risk adjustment.
Okay, I guess what I wanted to say on that is, two things. I personally am aware at a former workplace of management asking mental health clinicians to add in physical health diagnoses to the encounter diagnoses of the therapy session and just ask how the treatment is going, but not provide advice. But so I, personally have seen how it's the gaming that can easily happen. but that's just an anecdote. But one thing I'm wondering about is if there is diagnoses like looking at, like for mental health, looking at what encounters or what care the person received. Are they receiving what is considered the standard of care for that diagnosis? I don't exactly know how that plays in, but I'm thinking that may say something about are people getting the health care that they need? And then just to kind of make a comment on contracted workforce, which I'm currently working for a county mental health system, and I've worked for contracted providers. And it is true that I've been paid less and have been non-unionized at contracted providers. And, you know, if we're all doing the same job, treating the same population, it kind of doesn't seem fair to the contracted workforce or the contractor workforce, or it makes me wonder if they have more problems retaining staff because they aren't able to, or they aren't paying as much as like a county directly. But again, I'm not sure exactly how that relates, but I wanted to bring that up.
Great, thank you. We'll move to Ken and then we'll wrap up for public comment.
Really good presentation. Thank you. I just want to commend Elizabeth and everybody on your staff has done an amazing job conceptualizing all of this. I think it's incredible. I just want to be sure my understanding is correct with the eventual focus on expanding primary care. It is logical to assume that's going to bring with it increased cost. I mean, someone's going to have to pay for the additional responsibilities the service providers are going to be delivering. So there may be an upward push in this overall cost model, but I see that as an investment in long-term improved care that will be realized later on. Is that correct?
I mean, that is part of our intention, is that, you know, increased investment in primary care leads to overall lower healthcare spending, but it is definitely a long-term investment. And I think research, there is, you know, research from other countries that shows that's true, but there, you know, still to be determined how that works here.
I know it's difficult getting employer plan sponsors on the contractor side to understand you have to make an investment in order to realize savings later on, but this is great work. Thank you.
Sure, go ahead, Hector.
Yeah, I just wanted to underscore that's what this opportunity is with Medi-Cal, to show that increased payments to primary care reduces downstream costs, and we can do it prospectively because it's going to happen. But the other piece is looking at ACOs, Medicaid ACOs in other states and how they performed. I think that would be very helpful because those are fee for service. They're not HMO Medicaid. And they still allow that team-based approach to taking care of patients. So we have that in California in a different model. One is alternative payment model through capitation in all payer lines of business. And we also have ACOs. Some are the Medicare shared savings programs that also give you waivers to be able to do that for PPO and EPO type products. So we do have an opportunity to have alternative payment models just at about every place in California. And it also addresses the attribution issue that Michael was talking about earlier, because just like an HMO allows you to attribute to a primary care, the ACO allows you to attribute to a primary care as well.
Thank you. All right, we need to move to public comment now. I'd like to invite members of the public up to the podium to make a comment on this last agenda item, or also for general public comment. Inviting the same for the members of the public attending virtually. Please raise your hand. Noting that we have about 29 virtual attendees at this point. So public comment for this last agenda item and also general public comment at this time.
Okay, I just really want to thank everyone for coming today. It was just such an incredibly rich conversation, and also really want to appreciate Dr. Richard Pan for sitting here and taking all this input that he'll help us convey to our board members tomorrow.
Thank you. To the individuals who I had to cut off there, please, you are welcome to send comments to the office. So reach out to us afterwards and we will take all your comments. Thank you all very much. At this time, that concludes our meeting. We are adjourned.